Dr. Nosh, is somebody in his
It's 5:30.
The audio is not working properly, it seems, for the video.
Yeah, yesterday also we had the same problem.
Hi, Gaurav, Mohan, Dr. Kiki.
Hello, Ramu.
Hi.
Hello, Ram.
Hi, Dr. Lane. How are you?
I'm
Hi,
fine.
Amar.
Fine.
So first of all, welcome everyone for the second day of this annual IIRSI conference, which is a live virtual global conference. I want to introduce you also to some of the top people who are there with us. And we have with us key people who's the president of the AIOS. From the IIRSI, he is the chairman, scientific committee. We have Mohan Rajan as the treasurer of the IIRSI, another great doyen in ophthalmology. And another key person with us is Rohit Om Prakash, who is also the person who's organizing the winter IIRSI. So before I continue, we'll start first of all with Dr. Mahipal Sachdev, who will talk a few words. Mahipal.
Thank you very much, Amar, and a warm welcome to all of you from overseas and India. Good morning, good afternoon, good evening to all of you. We are going into the second day of the IIRSI, and this is an annual conference that we hold, which is attended by a lot of doctors from all over the world. But this time, because of the COVID, we are having it as a virtual meeting. And mind you, there are more than 10,000 registrations as we speak from over 130 countries. So it is widely being watched by people. And that is only because of the great speakers, the great international and the national speakers that we have. Yesterday, we had a lot of good talks, and today we continue with that for another 3 hours of academic and scientific skill resources that will be talked about by various speakers. Also, yesterday we had the annual Film Festival Award for the IIRSI, and today we will have the award within this session that will be on the ophthalmic photography. So without much ado, I will pass on for this first session, which is the anterior segment symposium, and we have as the moderator Professor Dr. T.P. Lahane. Dr. T.P. Lahane and Dr. Jagatram is here. We are both very, very proud of you because you are leading from the front the fight against COVID as the in Maharashtra and in Chandigarh. Dr. Lahane is the director of the medical education in Maharashtra, and he is virtually with his entire team spearheading the fight against COVID. And Professor Jagatram is the director of PGI Chandigarh, and he has done great service for the fight against COVID. Apart from that, we have Gaurav Luthra, who will be the moderator, and in the panelist, we have Dr. K.K. Mehta, who we all know is the Dean of Ophthalmology. He was Chairman Scientific Committee, President, All India Ophthalmological Society, but above all, he's a mentor and guide to most of us. We have Dr. Ramamurthy, who was also the President of All India Ophthalmological Society. He heads the Eye Foundation, a great scientist and a great ophthalmologist, trained both in anterior segment and posterior segment. Dr. Partha Biswas will be joining soon. He is the chairman of the scientific committee, and Dr. Naushir couldn't join, but he was supposed to be on the panel. So without much ado, we will go on to the various talks, and I pass on the entire session to the moderators, Professor Lahane and Gaurav Luthra. Gaurav Luthra is the chairman of the academic committee of IIRSI, and again, a very versatile surgeon and a great friend of ours. Dr. Lahane and Gaurav, please, over to you.
Thank you, sir. Sir, I think we'll start off with the first talk by Dr. Lahane himself. So I think Dr. Lahane again has been introduced so nicely by Dr. Mahipal. Dr. Lahane will be speaking on the IL scaffold, and we have 8 talks to go, and we have 4 minutes each. I'll request Dr. Lahane to please upload his presentation. Thank you.
Thank you, Gaurav. Thank you, Amar. Thank you, Mahipal. Now, this is the iris scaffold. There is a posterior capsular rupture with intact nucleus. And to overcome, there are 3 tips. If you can see that there is a posterior capsular rupture, and I am trying to just see, you will see supporting by the chopper, and then I am trying to remove the cortex. But at the same time now I will remember only one person, and the name of the person is Amar Agrawal. Whenever there is a such type of problem comes, then each person may be working in not only in India but anywhere in world, any corner you can see there is a PC tear. And now once there is a tear, then we must remember that as there is a rent, then there is Amar. And as there is Amar, then I think we should go to tip 1 is prolapse the remaining nucleus in the AC and fill with the visco. So the nucleus is to be brought in the anterior chamber, and after that the tips 2 is I will insertion under the nucleus and then fecoemulsification with minimal power. You will see this is the IOL I am inserting in. After the insertion of the IOL, I will see that this IOL normally we should keep on the iris, because if you go for the in the bag or on the capsule, that may also slip behind because of force of the phacoemulsification. Now here, the nucleus is a mature cataract, and with the minimal power of phacoemulsification, gradually, because it should not create a surge, otherwise the foldable lens will go behind and there will be another problem. So, and now you can complete. So the complete anterior vitrectomy and rotation of the IOL is important. Now see, this is the vitrectomy done. Then there is a rotation of the IOL properly, so that you will see the pupil, and then you can hydrate. And case 2 I will show you. In that you can see the again mature cataract. I am putting the iris IOL scaffold, and once this lens goes in, after that it should be fixed on the iris, and then you can rotate the nucleus in the anterior chamber properly, support the nucleus, and then you can do the phacoemulsification. So here you will see the gradual minimal phaco power, and minimal can see you can remove nucleus, maybe mature or maybe any type of cataract. But here the iris, this IOL lens scaffold helps you. And again the same, you have to go for the proper vitrectomy all over and then rotate the lens. And thank you, Amar Agarwal, for motivation. Because of you, we could do such type of surgery. Thank you very much, Amar.
Thank you, Dr. Lane sir, for that wonderful presentation. And IELTS Scaffold, of course, has been a very, very big savior for all of us in all these situations. And we thank Dr. Amar for that invention. I don't see Dr. Raghini yet, sir.
Ragini is unable to join. Her
Okay.
presentation is with me. Whenever we have got time, I will do that.
Okay, sir. So we'll run through everybody else's presentation, and then we'll see when.
And we will see if there is a time permit, we will do that.
Thank you so much. So I'll go on to our next presenter from the United States, Dr. Cynthia Matosian, and she's going to speak on alternate drug delivery for cataract surgery, and we look forward to hearing about that.
Then you can stop sharing.
Dr. Lane sir, can you stop sharing your screen, sir?
Yes, sir.
And can you see my?
Very much.
Can you see my screen?
Perfect. Thank you.
Madam.
Yes, you can see it.
Yes.
Yes, yes.
Okay, good. Hello, everybody. Thank you again for putting this amazing meeting on, Amar and your entire team. You guys are amazing. So I am going to be talking about alternative drug delivery for cataract surgery patients. These are my financial disclosures. We have come such a long way with fantastic implant options to provide broader ranges of vision for our patients, terrific IOL formulas, and really innovative intraoperative guidance systems. So why not also think about alternative or new drug delivery at the time of cataract surgery? Our patients are paying out of pocket their hard-earned cash dollars for premium implants. And of course, they want premium outcomes. And they're hoping for a premium experience in the perioperative period. However, about 75% of ophthalmologists in the United States, according to recent MarketScope data, are still prescribing topical antibiotic, steroid, or NSAID drops, and only about 20% are using intracameral antibiotic or steroid delivery. So what's the problem with topical drops? Well, we all know patients are notoriously poor at being compliant with whatever we recommend. With this age group, cataract surgery age group, patients tend to be elderly. They have trouble administering drops due to forgetfulness or dementia, or perhaps issues with manual dexterity. There are all sorts of callbacks and switch outs of branded medications to generic ones, leading to confusion. And caregivers and patients view drop administration and adhering to a schedule extremely confusing and burdensome. And if you look at the typical triad that we recommend, an antibiotic, an NSAID, and a steroid, each with different number of drops per day over different number of weeks, it leads to over 105 drops per eye. And that's not even taking the second eye into consideration if it's done within 1 or 2 weeks of the first eye. So you can see this situation is very frustrating to patients and caregivers. So now we have multiple new drug delivery options that we can either place into the anterior chamber or intracamerally, actually, at the time of surgery, or use an insert at the conclusion or pre or post surgery around cataract time. So this is my video, which I am going to share with you. This is using dexamethasone intraocular suspension 9%. I learned the hard way. You have to stromal hydrate the main incision and pressurize the globe to where you want the globe to be at the conclusion of the surgery. During this time, the nurse is preparing the dexamethasone. You go in through the side port and place it under the iris and pull right out. I know that was really fast, so I'm going to show it to you in half time. You go in with a 25 gauge or 27 gauge cannula. You place the tip under the iris, between the iris and the anterior capsule. Place the drop and snap the cannula right back out. This way you're breaking the surface tension and leaving the spherule there. And then you close the incision per normal. The other option is dexamethasone 0.4% intracanalicular insert, where you place the insert in the inferior punctum, and once it makes contact with fluid, meaning the tears, it starts to release the steroid over a 30-day period, similar to the intracameral delivery. And here is a video I want to share with you. And this is a patient who had 2 puncta. So I had to figure out which punctum was patent and which was not. So here I am trying to figure that out. And the first one was a patent punctum. So there is a dilator that you have to use to dilate. And during the dilation process, I also rotate the dilator. Then using a wax cell, you have to dry that area because the hydrogel insert expands as soon as it hits moisture. You hold it with a forceps and slide it vertically and laterally and push the tip all the way in so nothing is protruding at the conclusion of the case. And with this, we have multiple benefits. In summary, we're going to bypass the cornea, which leads to better visual acuity on post-op day 1. We are going to lift the burden of perceived burden of drops from the patient and the caregivers. We're going to have less negative impact on the tear film, and of course, take control over compliance so that the surgeon places the medication at the time of the surgery into or around the eye, eliminating compliance issues with patients. Thank you very much.
Thanks, Cynthia. That was amazing. Dr. Lahane, sir, any comments before we move on to the next talk in India? Are we getting anywhere?
We can go for next talk, no problem.
Okay, sir. So I think very interesting topic. We'll try to talk about this later on. I'll invite our next speaker, Professor Jagatram from PGI Chandigarh, who has many award-winning videos to his credit and won an award even yesterday in the IIFA festival, who will be speaking on the double lens.
Yeah.
Jagatram.
First of all, I am thankful to Dr. Amar Agarwal, Dr. Mahipal Sachdev, Dr. T.P. Lahane, Dr. Gaurav Luthra, and Dr. Rohit Om Prakash for giving me this opportunity. I am told to show this video, a very unique video, which I shared about 7 years back. That is the double crystalline lens. Here is the video.
Here is a child brought by parents at the age of 4 months, noticing an abnormal large right eye since birth. Subsequent examination of the child revealed an oblique right eye with 2 corneas joined together and a normal left eye. Under anesthesia with dilated pupils, presence of double crystalline lens was noted, separated by a small central clear aphakic zone suggesting incomplete duplication of anterior segment. Both eyes showed normal fundus with a good foveal reflex. Neuroimaging, including CT scan and MRI, also showed presence of double crystalline lens. Now what next? Plan for IOL implantation was conceptualized right from designing a special suitable IOL which could be placed into the capsular bag of both crystalline lenses. After multiple brainstorming sessions, we conjured an IOL design with maximum overall diameter of 18 mm. The central optical zone is 6 mm with surrounding 2 mm extensions. The initial steps resembled those of any pediatric cataract surgery. We performed 2 anterior continuous curvilinear capsulorhexes, one by one, started with cystitome and completed with Putrata's forceps in both the crystalline lenses separately. Multi-quadrant hydrodissection was followed by standard steps of phacoaspiration. Specially designed acrylic foldable IOL was loaded in the cartridge, followed by injection of viscoelastic material and the IOL implanted in a way so that the leading haptic goes into one capsular bag and the trailing haptic into the other. Both haptics are now secure and the optic lies in the central part. Presence of zonules connecting the 2 capsular bags is clearly demonstrated. Incision closure was ensured. Removal of viscoelastic material and standard steps of closure followed. 6 months post-operatively, the intraocular pressure was 10 mm of mercury and the spherical equivalent obtained by retinoscopy was 5 diopters. Examination under anesthesia reveals clear visual axis, round pupil and a well-centered IOL. The central clear visual axis at the time of surgery measured 1.5 mm. As anticipated, there was progressive widening due to contraction of the capsular bags, increasing the dimension of this clear area to 3 mm at 6 months. The clarity of the visual axis further increased to over 4 mm at 1 year. The amblyopia therapy was already instituted for this child in the post-operative visits. This child is able to walk, play, and catch objects with occlusion of the normal eye. This child achieved a gratifying visual outcome after implantation of a specially designed, customized intraocular lens followed by appropriate amblyopia therapy. Thank you.
Thank you, Jagatram sir. That was an amazing video, and every time we see it, we love it. It won the best of the best awards at the IIRSI. I remember that. I was present. So thank you so much for sharing that. And I think we'll quickly go on, and I'll invite Carl Stonecipher. We've learned a lot from him over the years, a lot about laser surgery. And today he's speaking on a very interesting topic on the laser floater treatment. And all of us are very keen to hear about this in India. So Carl, please go ahead.
Sure. Hey, Dr. Carl Stonecipher here in North Carolina. And I've got to say the same thing Cynthia said. The Agarwals, you guys have done an awesome job. I had like 3 computer screens yesterday watching all the little different sessions, and it was pretty spectacular. I like Dr. Steve Slade. I was hoping to bring the family. So if I do a good enough job, maybe you'll invite me next time when it's back in India. So floater therapy, when, how, who, what do we do in terms of the big picture? And I think if it's visually significant, then it's an option now, and we have options to do that with. This is a good slide from a friend of mine, Dr. Paul Singh, you all know well. If you have a 65-year-old male, they come in, they complain, they can't see at night to drive, they have troubles reading, they glare to 20/60, we're going to do cataract surgery. It's pretty simple. But if you got that guy that's shaking his head and says this thing's moving in front of his vision, you might say, and many of my colleagues say, well, don't do anything about that. It's a floater. So I think we have the opportunity now to do things to treat these people, because roughly 7 out of 10 people will have a floater at some time in their life. My partner, who is totally negative on floater therapy, now has one, and now he's talking to me about fixing that as we go down the road. And there are people that have psychological disturbances from this. So a lot of these patients come in and say, it's a real issue for me. They come in all shapes and sizes. And so for the most part, in the lower left, we see these well-defined floaters are the easy ones to do. The cloud-like ones are a little bit more of a challenge. And they're more of a challenge because it may take more than one session. If it's not successful, vitrectomy is an option. I do think that you need this. Yes, I'm a consultant to Alex. Yes, I speak for Alex. Yes, I do research for them. But I think this laser is true, the issue. I do use the Sing lens. I think this laser is important because it's coaxial in terms of its illumination. The energy delivery system and the stable cooling cavity are all imperative. Don't try this at home with your typical standard YAG laser. They're great for capsulotomies and iridotomies, as this one is as well, but you have the risk of a limited view of the vitreous and risk to surrounding tissues. I do align myself with all the colleagues that are in retina. I tell them that, hey, I may need you down the road. I have 6 great retina surgeons around me, and now they refer patients to me on a routine basis and say, hey, you try the laser first, and then if it doesn't work, we can go ahead and proceed with vitrectomy if needed. Is it successful? Yes. There's plenty of studies out there now. Karakoff's book is who I'd refer you to. When I was in residency, what we learned about the vitreous was to avoid it during cataract surgery. This is a compendium on the vitreous and how to treat this. I have over 99% of my patients happy. The other 1% that aren't happy, those are the people that probably are getting referred to retina. Now, does everybody go to retina if we don't get it all? No, a certain number of patients will decide, hey, I can live with that. But here you see a large mid-vitreous floater that's being treated with the laser with photovaporization. Here's my favorite, a before and an after. You see the floater's gone with the bubbles, and that's a way you can tell the patient that we're actually vaporizing this tissue, and you see it going away. Here's Dr. Singh's data. He's presented on several occasions. The 3 biggest things are intraocular pressure, you don't want to hit the lens, and retinal hemorrhages if you hit the retina. The lens is the biggest issue, and I admonish anybody that gets into this, definitely do your first 50 cases with pseudophakic patients. A lot of us aren't used to using lenses. Retinal hemorrhages aren't as bad as this. This is a problem, and you get an instant cataract. So with the retinal hemorrhage, I've hit 2 retinas in my career. Getting too close, we're always looking forward, looking back, looking forward, looking back. But I think in terms of the big picture, they were innocuous and there was no sequelae. My good friend, Dr. Shah, has published this and showed it that versus sham, it really does make a difference in patients. So I think this is the first retina person to publish. And since then, the retinologists have been more on board. So start with pseudophakic patients. Think of the concept of enhancement. Complications are rare, but you can avoid them with careful planning, and never promise too much. Thank you guys very much.
Beautiful.
Thanks, Carl. Yeah.
The regular YAG laser, Carl?
Beg your pardon?
The regular ND YAG laser, what we use for the capsulotomy? The same laser?
No, we use an LX laser, and I think the LX laser is important because of the coaxial illumination. Now, if the floater's right behind you, yes, you can treat with your YAG laser, but to get in the posterior pole as well as to get in the periphery, I think the Alex laser makes a huge difference. And again, I'm a consultant to them, and I have to say that, but I think for the most part, the laser, you know, a good worker never blames their tools, but this laser makes a difference.
Okay.
Great. Thanks, Carl. Thanks, Dr. Mohan.
Thank you.
I'll quickly go on. I'll invite our next speaker, Dr. Keith Walter from USA, who's again going to speak on a very interesting topic. He will be talking to us about femto-assisted corneal tattoo, and let's see how to do that.
Yes, and ditto what Carl and Cynthia said earlier. Thanks for having me, and what a wonderful program this has been, and it continues to be. I'm glad we're able to do this, even if it's not live. So I'm going to talk about femto-assisted corneal tattoo. I think an easy way to reduce glare, polyopia, and photophobia without having intraocular surgery. So I don't have any financial disclosures to declare. Traditional tattoo you can do with a needle, and of course, if you put enough little pixel marks with a handheld needle, you can cover iris defects. But of course, these are very painstaking to undergo. The patient can have some prolonged pain, and it's a prolonged effort for the doctor. It's about an 80% chance of a recurrence of needing to apply more pigment, because you really can't see where the pigment is going. And afterwards, they fade or migrate out of the cornea. So it's not a great way to do it. And so we've always looked for alternative ways. Over a decade ago, Kimonos described a way to do covering a white pupil with a femto LASIK flap and just painting underneath the flap. And of course, that kind of got my interest on how we could do this even better. So what I like to do is either a partial LASIK flap or use the Intax ring segment software. I've now done over about 200 cases. Here's a case example. A 39-year-old comes in with a paintball injury. Traumatic cataract was repaired, but had an iris tear at 7 o'clock. Complains of edge glare, light sensitivity. He has to close one eye to cope, which is not very comfortable for his job. And he's been contact lens intolerant for the last few years. You can see his photos here. You can see why he would have such complaints of edge glare. And of course, you could surgically repair this by doing a seep-through stitch. But maybe a more elegant way is to bring out the femto, do a Intax software with a wide channel. And you can see I put the entry and exit channel right over that iris defect, and then you can apply pigment in there. This is a different case of actually a smaller iris defect from a laser iridotomy. But of course, you can do the laser, and then you can just widen that channel. You can't really inject the pigment as you think you might be able to. You actually do have to place the pigment in there. And then once you start putting the pigment in there, this is just simple pigment from a company called Paramount. I have no financial interest. You can sort of impregnate the area with the pigment just by simply going in that channel where you widened it and then placing the pigment there. Very easy to do. This is his post-op appearance on the traumatic. And of course, I've gotten very good at matching the iris color, so it's hard to see his left eye. You can tell by the femto suction mark. He's a day one, but it looks very good on day one. Up close, you can see where the pigment's been placed over that iris defect, covering it quite nicely. This is a slit lamp view of the pigment placement, showing that it's just a very thin layer of pigment. So let's look at another case. These small laser iridotomies that we're seeing a lot, especially for ICLs, aren't benign. They do cause a lot of issues. This is a 30-year-old who got her iridotomies prior to her ICL placement, but couldn't tolerate the extreme horrible glare, she called it, and polyopia she had in her one eye versus the other. Her lid anatomy was a little bit atypical, and you really can't see these iridotomies when her lid is in a normal position. And so she was very much discouraged by her other doctor, who discouraged any kind of further treatment because he thought that she was a little bit crazy and shouldn't have these symptoms. But when you lifted her iris, you could see these holes quite nicely, a little bit on the large side. She had a remarkable improvement with holding a finger over that temporal area. And there has been described sort of a prismatic effect of the tear film against the upper lid, shooting the sort of light into that hole, even though the lid covers it and you think it wouldn't. For her, I did a boarded LASIK flap, just started the LASIK flap, then stopped it. I did it 200 microns deep and did a kind of a wide channel so I could get access to it and place the pigment over that area. Post-op, you could hardly see the area I covered, but I did have to cover a little bit below her lid margin so that she could actually not have that light shoot up in there. What about temporal PIs? Well, they're not any better. Some people think if we do a temporal PI, we'll have less edge glare. They actually probably have more. I see a lot of these patients. This was a femtosecond Intex channel where I just placed the pigment. You can see I color matched it a little bit better than that earlier case. When we do this, it completely resolves their issues. They have no more issues of edge glare. So it's about 100% success rate for the laser iridotomy patients. We also see a lot of patients who've had temporal cataract in surgery with floppy iris syndrome, and they also get a kind of a moth-eaten iris and have edge glare as well. This is what we did for this lady, and this is her post-op period. You can see the smile on her face. She's very happy now that she no longer has that edge glare. These are several other examples. A case of traumatic aniridia is on the top. Again, some more peripheral PIs that are causing edge glare, and then another trauma case. So what about changing eye color? I get that question asked a lot. Could we just purely do this for cosmetic reasons? These slides are courteous of Dr. Ferrari of Paris, who has a company called IIRSI, and he actually is doing that. He has a way to widen that channel even further and place the pigment in the eyes, and he can change your iris color. I think it's up for ethical debate whether we should be doing this on a lot of patients, but I think there is a market for it. All right, and thanks for your attention.
Thanks, Keith. That was fantastic in that short time that we gave you. And, it's intriguing how you can match all the colors so nicely, especially in the US, you would have a whole range of different iris colors. In India, we have it easy with just the brown shades of brown that we have to deal with. But I think we'll come back and I'll quickly invite our next speaker. We have none other than Kathleen McCabe, and then she's going to speak on 5-0-proline scleral fixation technique for subluxated IOLs. We can't hear her actually. Yeah. You can go ahead, Kathleen. Yes. You have to unmute yourself, maybe. We can't hear you still. Can the admin help unmute Dr. Kathleen?
There we go. I
Perfect.
think I've got it now.
Yeah.
Yeah, my other button disappeared for some reason. I'm sorry. So yes, I want to echo my colleagues in saying how wonderful it is that the Agarwal Group puts on such wonderful educational opportunities. And I also hope that I can have an in-person visit there in Chennai and see all of you with my family as well. So I'd like to present, though, the 5-0-proline belt loop technique for scleral fixation of dislocated in the bag IOL complexes. And this is becoming a bigger and bigger problem for a multitude of reasons: pseudoexfoliation, eye rubbing, like you may see in this patient on the right, trauma, capsular phimosis in cases like retinitis pigmentosa, or complicated primary cataract surgery. And there are many different ways of dealing with this. 9-0-proline can have the increased risk, though, of suture failure over time or exposure of the knot, and really any suture material can cause exposure of the knot. You may have to exchange the IOL, and during those procedures, almost invariably, you have to do an anterior vitrectomy. There's risk of loss of cortical material into the posterior segment or even the lens itself. There is the possibility of trauma and damage to the iris or the cornea or even the lens as you're trying to put in a new lens. And those are not ideal. There are lots of different ways of dealing with an IOL exchange and putting a new lens, like the Yamani technique or glued IOL or double flange. If you're exchanging the lens or using one of these other fixation techniques, there are a lot of skills that need to be acquired. And again, you need to have a new lens, which if you've paid for a premium lens the first time, that may not be ideal. And so what we can do instead is take a section of 5-0-proline. 5-0-proline looks the same as a haptic, the same diameter. You can use that to create a belt loop with phalanges that goes through the capsule, actually, through any cortical material that may be residual there that just helps give it extra girth, and around the haptic. And that will secure the lens. And so this is actually my second case of doing this. And let's go back there and Hold on one moment. That was a quick case, wasn't it? Let's see if we could get this to play. There we go. So this is a case of a patient who came in. She had had a Technis multifocal lens, and she was very keen on keeping her lens, and it had dislocated superiorly. And what I decided to do was try this fiboproline technique that I had actually seen used in a session for teaching the Yamani surgery. What I did is put a 27 gauge needle through conjunctiva and sclera, 2 millimeters posterior to the limbus in the area of dislocation where the haptic was. And I threaded the fiboproline cut piece of suture into that 27 gauge needle, withdrew it after it was placed through the capsular bag and under the haptic, and then placed a second needle 1/2 millimeter anterior to that and threaded the opposite end of the cut fiboproline. So now we have a belt loop that's going from sclera around the haptic, through the capsular bag, through the sulcus, and back out through sclera. And with low temperature cautery, you can melt those ends, get a flange just like the Yamani technique. These little flanges that you can see in this case are a little bit large. It was an early case. You really don't have to make them that large. You can see by shaking the eye around, it was very stable. And this is the postoperative appearance. You can't see the belt loop when she looks down and she's dilated. You do see the little flanges at the surface of the sclera, but this is a well-centered, looks just like the day she had her lens put in. No vitrectomy was necessary, no loss of cortical material. She didn't lose her premium lens that she was really anxious to keep, and she had a great result. And at this point, really the technological requirements are so minimal. You need fiboproline. It doesn't matter what needle you order because you're not using the needle. You'll use a 27 gauge needle, and now I use 1 1/4 inches because it's actually easier to externalize that end of the needle through one of the paracenteses and then thread the fiboproline externally. You just get a better angle. Low temperature handheld cautery, and then an intraocular forceps to assist in getting the needle through the capsular bag. It's appropriate for single piece acrylic lenses, 3-piece IOLs, multifocals, EDOF, hydrophobic, hydrophilic, doesn't matter, with or without a CTR, with capsular phimosis. If it's completely dislocated, you can put 2 of these belt loops, and that works really well as well. So I've done this on numerous cases now. Tim Page just did it recently too with a plate haptic lens just by putting the fiboproline through the fenestration. And in many of these cases, it does avoid having a new lens, and it avoids an anterior vitrectomy. So thank you for your attention.
Thanks, Dr. Kathleen. That was amazing. You made it look so simple and it looks so elegant. And I think many of us are beginning to start doing this, in different ways, and it looks really nice. So we'll quickly come back after this last talk, and we will have 2-3 minutes for a quick discussion. I'll invite Dr. K.K. Mehta, sir, who is going to speak on secondary piggyback IOL for effective presbyopia control. Dr. K.K.
Okay. I'm going to talk on secondary piggyback IOL for effective presbyopic control. As we are well aware, over a period of time, there is always a group of people who have been operated and now come and tell you that I need to be able, I don't want to have reading glasses, I want to manage without. And this group is progressively increasing every year. And therefore, these patients, essentially, a lot of them have been adjusted for far and near, or have just been given distance-based glasses, and the rest has been ignored. So you have a whole host of patients which you can now accommodate into this concept. I normally use a Rayner Sulcoflex trifocal IOL, which can be placed over the already pre-placed unit. It's an excellent lens, it has good transmission. I have nothing to do with Rayner whatsoever, and 89% of the light transmission. So essentially, once it is put in, the patient's ability to get intermediate and near both improve quite significantly. Fortunately, with this sort of a pattern which they have got, their unique conventional piggyback system, it minimizes the possibility of interaction with the primary IOL. So your red dust syndrome doesn't really occur. And the power calculation is fairly simple. You use the Barrett's formula. You use the pseudo-faking A, subtract the power of the previous IOL if available, and try and use an alternate lens. The other alternative is, in case the power is not known to you, you simply set the dials of the instrument to get the residual refractive power, and the difference is the exact power of the IOL. Inserting it is fairly simple. Just want to show you some of the quick results in the last 225 cases, because we are doing a lot of these now. You don't have to wait for new cataracts to appear. All the cataracts your friends have done are now, as one would say, meat for you. And these were the ones which were done prior, and to them we did the piggyback, and the accuracy is fairly high in almost about 90-95% of the cases. The complication rates are negligible. Basically, all of them involve the problem which occurred during the time when you needed to open the iris to put it in. But the cautionary remark is the patient must be explained in full. Why? Because whoever sees this patient after, you will tell him that though they have put two lenses in the eye, and somehow, despite all the explanation we do, the patient feels that the primary lens must have been removed. And so when he's told a double lens is there, he gets a bit of a shock. In summary, it's an excellent technique, corrects residual presbyopia dramatically. We have a whole host of patients who are most happy to have it done, and it's something which you should consider as a regular routine. You see a patient with mono lenses in the eye, promptly lead him down the road, as one would say, to a piggyback lens. Thank you for your attention, and thank you, Amar and Mahipal, for this wonderful meeting.
Thanks, Keki sir, for that fantastic presentation, and you're bang on time. Without wasting time, I'll take a quick word from Dr. D. Ramamurthy sir, if he's still here, on his comments on the alternate drug delivery for cataract surgery, which Dr. Cynthia spoke about. Can you, what are your views on that? Is anybody in India using that? Sir, can you stop sharing your screen, Keki sir? Wonderful.
I think it's a wonderful concept. As was mentioned, there's so many advances that have taken place in all aspects of cataract surgery. But still, we expect our patients to apply drops for 4 to 6 weeks. And obviously, this would be a great way to go. I have tried this with injecting, posterior subtenon steroids, and it did help and cut short the amount of application of steroid drops that was necessary. But these are more elegant ways of doing, and I think that some intravitreal implants are also that's coming in. Obviously, something which you can put in the bag would be a good way to go. I think we should wait for approved drug delivery systems like this to become available to India. I think it's a great addition to what we have.
Sure, I think that'll be a great way to go. I'll take comments from Dr. Partha Biswas on the laser floater treatment that Dr. Carl Stonecipher spoke about. Do you have experience? Do you know anybody in India? Because the LX laser, I don't know who's using it, but
yes, thanks, Gaurav. The Alex laser, I think, we are not quite aware of the Alex laser, but floterectomy and as well as the floater treatment by the YAG laser has been tried in different parts of India as well. But Dr. Karl has got a large experience. And would you like to tell how the Alex laser is different from the other lasers, sir?
Yeah, I think the biggest thing is the illumination. It's coaxial, and so you can kind of do this on-axis, off-axis, where you can get better visualization. They've got a stable cooling cavity, so you can fire multiple shots without the laser getting too hot. And then last but not least, the way the beam energy is delivered, most of that energy is coming back at you. So in terms of, worrying about hitting the retina is part of the issue with the laser. But I think it's really the energy delivery system, but mostly the coaxial illumination that helps.
What's the wavelength?
The wavelength is 1064, if I remember correct.
Same as YAG.
Yeah.
Great. I'll take a quick last comment on the talk on the femto-assisted corneal tattoo by Keith, and I'll request Dr. Mahipal sir he has experience with this, so I'll request him to share his wisdom.
So I think this is a great way. Tattooing is something that was there used earlier, and now it's coming back in vogue. And I think the videos that were shown by Keith were really fantastic. And as you rightly said, we'll have to match the color of the iris depending upon the tattoo that has to be done depending upon the color of the iris. I just want to check out with Keith, is this permanent? It, it stays all along? For how many years do you have a follow-up?
We just submitted a paper where our average follow-up was 6 years. And we looked at actually a different angle. We looked at improvement in visual acuity. And we were surprised that we actually got on average a 3-line improvement in visual acuity and best corrected visual acuity. So you don't really think too much about the second image coming from a second pupil, but it does interfere with their visual acuity. So we've got a lot of experience. My predecessor, John Reed, who used to do them all by hand, had about 30 years experience doing corneal tattoo. And then I've been at Wake now 24 years, and we've been doing this for probably the last 15. So we've got a lot of experience on these patients, and they do very well.
Great.
Thanks. I think we have just 5 minutes to declare the results of the ophthalmic photography competition. We would love to have talked to more with everybody. So I'll be announcing the awards. I'll take the help from Dr. Kumar, doctor, and who has been one of the chief judges, and Dr. Manish Nagpal, if he's able to join. And so So we had a lot of submissions this time, huge interest. We had 550 submissions and 322 in 6 categories for the ophthalmic pictures, and for the non-ophthalmic pictures in 4 categories, 279 entries. We took help from this group of judges led by Dr. Kumar, Dr. Rajesh Fogla, Dr. Ashish Nagpal, and Dr. Rishi Swarup for the ophthalmic categories, and for the non-ophthalmic categories, Dr. Manish Nagpal, helped by Dr. Ron Ryo from Singapore, Dr. Shobhit Chawla, and Dr. Som Prasad. And of course, our IIRSI office bearers always standing by to help us. The awards, we have category awards in each category for the winner and the runners-up, and 3 grand prizes sponsored by My Healthscape, Mr. Monish Bachu. For the first prize is the iPhone 11, a second prize for the Samsung Galaxy Tab, and a Fitbit. Let me quickly go on to announcing the awards. I will announce, in absence of Manish Nagpal, I will quickly announce the non-ophthalmic categories. He was not able to join at the last minute. So in the people's category, the runners-up picture was by Dr. Nikita Rajkonwar from Nagpur. And she gets the runners-up award for this category. And in the people's category, the winner is Fury by Dr. Prakriti Chaurasia from New Delhi. So both of them deserve congratulations. And then going on to the next category for the places in the non-ophthalmic categories. This is a picture by Dr. Rinki Agarwal from Noida. It's a place called Monument Valley in the US. And you can see that this was the runners-up award for this category. And then the winning submission here was the Govind Sagar Lake, the banks of the Govind Sagar Lake by Dr. Abhay Gupta. He's from Naya Nangal, and he has shared this nice picture. Going on to the third category in this group was nature, and the runner-up was Dr. Sudeep Ray's picture from Durgapur on the fairies bath. And this was followed by the winning submission by Dr. Apurva Goel from Hisar on the Great Migration and Life and Death at Parade. This was the winning entry from this category. I wish we could have spent more time, but we are behind schedule. The fine arts category, the runner-up was Dr. Anup Singh from Satna. A photograph taken while preparing for final MS exam shows conflict between past, present, and future. It's called The Prism, and a unique picture there. And in the fine arts category, the winning submission was this image, Sushantika, by Dr. Shaila Kalantri, and from Nanded. And picture is labeled title made. So these were the 4 categories, and I'll now invite Dr. Kumar, doctor, to please join and read out the winners of the other categories. Here I would like to qualify by saying that we did have this requirement that all images should be owned by the people who have submitted them. While majority of people have got back to us, there were 3 or 4 people whom we will remind again. And the awards are only eligible if you have made that disclosure that you own these pictures yourself and they were taken by you. So going on to the ophthalmic categories, Dr. Kumar, would you like to join here?
Thanks, Gaurav. It was fantastic doing this part of it, and with the help of 3 other judges. First category of external photography, the runner-up was from Haridya Mohan from Coimbatore on neglected hypermature senile cataract sequelae. So this was very interesting. And the winner in the same category was of external photography, The Dangerous Valley in the Eye from Rahul Kumar Bafna from Delhi. So this was a very important showing that the loose sutures and of course the visualization of the choroidal mount. The next category for ophthalmic was smartphone photography, and the runner-up was Pratik Tiwari from Gwalior. Of course, microsporidal keratitis in a young female, which we found very, very interesting, very good from a smartphone, very well focused and well centralized. And again, the winner in smartphone photography, this we were very impressed by, was Harika Regani from Hyderabad, a conjunctival melanoma, calling it the muddy magma. The next category, again for ophthalmic in slit lamp photography, and the runner-up in this category was very interesting about Santya Nagamaya from Coimbatore about an albino eye, and that you can see the whole lens through and through. And the winner in this category for slit lamp photography was Dr. Achal Thakur from Chandigarh, and you can see a well-stained cornea, the rose Bengal stain, and the red spring coil. We have one or two categories still remaining. The eyes as an art, and the runner-up in this category. This was very interesting by Dr. Kirti Singh, where you can see him taking a photograph and calling it the Purkinje confusion called the crystal ball. And this we thought was deserving the winner in the same category. The eyes and art is called the full moon in the eye, the zonular cataract by Dr. Sharon D'Souza. So this was again on the slit lamp photography, the winner. I think we have one more category of fundus photography. The runner-up is Dr. Nagesh C.K. from Bangalore, the resting worm. And this location I thought was fantastic because it's right in the center on the macula. I've seen worms subconjunctival and in the aqueous, but I've never seen this before. And the winner in the same category of fundus photography is by Dr. Purna Chandra from Bangalore, a colorful star sky, and truly it is a colorful starry sky. So this was the winner in this category. I think we are done with ophthalmic, and Gaurav will have to declare the three main winners after the ophthalmic and the other external photography.
Thanks, Kumar, there's one more category.
Yeah, okay, there's cross category, and the runner-up in this was Asmita Patni Chauhan, and this was about an inner perspective, about a double bubble in the vitro capturing both the bubbles, the outer and the inner, on type 1 and type 2. And then the winner in the same category of cross category is Samit Mehta from Jamnagar, and this was an OCT image showing the too close to comfort, which we thought was a Peters anomaly of a 1-month-old baby, which we thought was very, very well centralized. Very difficult to click a 1-month-old baby, but this we thought was an excellent image. I think we are done now.
Yes, Kumar, thank you so much. And now coming on to the final three prizes, which were selected from this group itself, and the three best entries. The second runner-up for the first runner-up, I think we got a small mistake there. This was the second runner-up. So we are starting the wrong way because of some glitch in the PowerPoint. This was the first runner-up, and that is the entry from banks of Govind Sagar Lake. We already saw this by Dr. Abhay Gupta. So he goes away with the Samsung Tab, and he's sharing a photo at the banks of the Govind Sagar Lake in Nayanangal. And the other runner-up was the category of the Great Migration, Life and Death at Parade by Dr. Apurva Goel from Hisar, both from the non-ophthalmic categories. And the winning entry, which gets the iPhone 11, is the grand prize winner. And that was the corneal staining with rose Bengal dye for the dendritic ulcer by Dr. Anchal Thakur from Chandigarh. And Monish, if you're here, he's been kind enough to sponsor all these prizes. My Healthscape is doing great work. Monish, can you say hello to everybody, please?
Hi, good evening, everybody. Pray everyone as well during these COVID times. Lovely show, great talks.
Thanks, Monish, for helping out. And I think we are done with all the awards. And I will, like to pass on back to our hall moderators to say a word of thanks to all our foreign speakers and our local speakers. Dr. Mahipal, Dr. Amar, sir, please take over.
Thank you, Gaurav, very much. Admin, can you have your ad? We request also those are the first symposia. You can just go log out from the video and the audio. You can watch it on the IIRSI.com website. Admin, we'll be starting the second session soon. Can you have your video coming up? Well, ladies and gentlemen, welcome to the next symposia. And before I talk about the symposia, I'll introduce 1 second Dr. Mohan Rajan, who's the treasurer of the IIRSI. A few words from you, Mohan.
Thank you, Amar, and it's been really a fantastic 2-day conference, and we have touched close to 12,000 registrations from over 130 countries, which is a huge record by itself. I think hats off to your team and the entire IIRSI team as well. And we have been having a very stimulating session. We're going to have a very good session in the next 45 minutes on iris repair and pupilloplasty as well. And I have the pleasure of introducing the two moderators for that.
Thank you very much, Mohan Rajan. I'd like to introduce, first of all, the chairman of the scientific committee, who's also not only chairman scientific committee IIRSI, but the president of the All India Ophthalmic Society, and one of the doyen figures in ophthalmology with more than 60 to 70 centers in his Center for Sight. Mahipal is a person, to be honest to you, he is an entrepreneur, but he's an academician also at the same time. He can talk with the equity players, he can talk with the academician and the scientists at all. So I'd like to ask Mahipal to introduce the next symposia. Mahipal.
Thank you very much, Amar, and welcome to the next symposium, and that is going to be on iris repair and pupilloplasty. I think, again, we owe a lot to Amar for bringing in the pupilloplasty and the role of pupilloplasty in difficult situations. And I think Priya Narang, who is going to be one of the moderators, has done extensive work on iris repair and pupilloplasty. And she will be the co-moderator. With her would be Mitch Wickard. And we have an expert panel, and that is Alan, Deepinder Dhaliwal, William, and Tala Raviv. So I think this is going to be a great session that we are going to have as a follow-up to the anterior segment symposium. Overall, as Mohan was saying, it has been a scintillating performance of the talks by everybody. Though these are short talks, we have kept them in a lot of video presentations. I think the delegates are learning a great bit from this. So without much ado, we will go on to this particular session of iris repair and pupilloplasty, which is something very, very important that all of us should be aware as to what are the new surgical tricks that are being done in this particular field. So over to Dr. Priya Narang from Ahmedabad and Mitch Wickard.
A big hello to all. Thank you for bringing in this wonderful session. So Mitch, let's take over this session.
Sounds great.
Yeah, and we are really delighted to have such great speakers and panelists for this session. So I think, Mitch, apart from being a moderator, you are the first speaker for the session. So let's begin with you. Yeah.
That sounds great. I think they have my talk in the system.
Okay. The admins, can you please run Dr. Mitch Wickard's presentation?
Yes, we're playing.
No audio. Can we stop there? The audio isn't playing.
Admin, could you?
Is there an audio in this, Mitch?
Audio is not
Yes.
there.
Yeah, I can play it from my computer if you'd like.
Oh, okay. Maybe if there.
We are checking. We are checking.
Admin, start again, please.
Yes, I will start again.
Through my one parasympathetic. Hello, I'm Mitch Weichert, and I'm going to be talking to you today about the single pass fourth row pupilloplasty. I learned this technique from Amar a couple years ago, and it's become an indispensable part of my surgical armamentarium. I like to make 2 paracenteses on each side of the iris defect. I'll pass a 9 or 10-0 Prolene on a long curved needle across the eye and externalize it on the opposite side. We'll then take one end of the suture and pull it through the opposite paracenteses And I like to verify the long end and have it between each side of the suture. We'll then take the free end and pass it around the side of the suture 4 times. We'll grab each side and pull the long side first to internalize the knot, and then we'll pull each side together to tighten the knot down. This is a case of a patient who had ocular trauma and underwent a penetrating keratoplasty and suture fixated IOL, but remained with this iris defect. So here I have my tenoproline, I pass it through my 1 paracentesis, and then I just externalize it on the other side. Now here I'm just passing it straight through the cornea. We could also dock it into, say, a 27 gauge needle through a paracentesis on the opposite side. I'm going to use some hook or snare to externalize the loop from the other side. And then I'm going to identify my long side of that suture, and I'm going to pass my free tail around that 4 times. Now I can do this in a variety of fashions. This time I'm looping the suture around my tying forceps. I will grab that free end, pull the loop off of the forceps, and then I'm going to grab each side of the suture and internalize my knot. And then once the knot's inside, I'm going to pull on each end to tighten down that suture. I do this a little bit at a time until the suture is tight. Here I'm creating another paracentesis opposite my defect, so I can cut my suture tails with some intraocular retina forceps. I've started to approximate my pupil here, but I've got a larger defect, so I'm going to do a few passes here. Now, here I'm externalizing this needle, which is a CIF4. It's actually a vascular needle. It's a little thick, which can create a corneal defect that may not close. So oftentimes docking into a needle is a little bit more beneficial. Now, instead of winding around forceps, this time I'm just going to take and do a handoff technique and pass this suture around my loop 4 times. And honestly, this is a little bit easier method for doing that. Again, I'm going to grab the opposite side and internalize the knot, and then I'm going to pull on each side to tighten the knot down. And you can see my defect is starting to close very nicely here. I think I need 1 more suture to close this defect completely. When you're passing the needle through the iris, you want to make sure that you've got good, healthy iris tissue, and you're not in an area of atrophy, so the tissue will stay closed. I think it's pretty remarkable that these defects and this suture will stay tightened with just this single pass with the 4 throws, but it definitely speeds up the surgeries and makes it a lot easier. So I'm going to cut my tails here, and then in this case, my pupil is not quite centered, so I'm going to open it up a little bit. It's a little ovalized, so I'm going to do a few small sphincterotomies here. Less is definitely more when you're doing pupillary sphincterotomies. You don't want to make them too large. You can actually get a pretty large pupil that's bigger than you intend. I'm going to cut off some of these tags to make sure my pupil is really rounded out here. You can also use intraocular cautery in the mid-periphery of the iris to do this as well. And you can see once I've got my last tag here, and I remove my viscoelastic, that I'm ending up with not a perfectly round, but definitely a cosmetically pleasing pupil here. It's a nice size as well, not too small. The patient was very pleased, and we were very happy with our results. So thank you. Again, this is the 4th row pupilloplasty, an excellent technique to add to your surgical armamentarium. I think Priya's up next. And can you unmute, Priya?
Dr. Priya, unmute.
Yeah, my screen is visible, I suppose, right? So
yes.
Yeah, I'll just play my presentation now. Well, I'll be covering up the iridodialysis repair, and I'll be talking about the 2-pole and the trocar-assisted method. At the outset, I would like to thank Dr. Amar for this wonderful opportunity. I think my presentation is not playing. It's not playing. I'll do that again. Yeah, sorry for that. So the initial thing, the first technique that I'll be covering is the two-fold technique. This is a technique we just published into the Journal of Cataract and Refractive Surgery. So basically, for iridodialysis repair, we try to categorize the amount of iridodialysis that is actually present. We have just briefly categorized it into the massive, which is considered to be more than 120 degrees, moderate, which is about 45 to 120 degrees, and minimal, which is less than 45 degrees. Actually, for the two-fold technique, it is basically a combination of non-appositional iris repair, which has been described by Dr. Snyder, and it's a combination of single-pass photocoupleplasty procedure that has been described by me and Dr. Rama. So actually, using this combination in various methods, you can have a wonderful iris repair even in the most complicated situations. So that is what the two-fold technique actually is all about. So I'll be just going through the animations. I'm just trying to show you. For example, if this is a case where there's a massive iridodialysis, the initial repair will be by the non-appositional method. So you just fix up the base of the iris into its original position with a double arm suture, which has been described before by Dr. Snyder. Once you have done this, the non-appositional repair, you might have correctopia. You're obviously going to have it because whenever you have a massive iridodialysis, you have the element of correctopia, which can be corrected with this. So this method is actually very helpful when you have massive iridodialysis coming up. For example, in a different situation where you might have a sectoral involvement in this case. So what actually we do in these cases is that initially we do a single pass photocoupleplasty. And you can just see that we close down this defect quite a bit, and there is a narrowing out of the defect here, and then you can just fix up the base of the iris with the non-appositional method. So these are the various kinds of combinations that we try to use up even in the even in major iridodialysis repair or in minimal iridodialysis repair. So this is a moderate amount of iridodialysis repair that you are seeing it, and this is the single pass photocoupleplasty procedure which is being adopted. We pass it from the proximal and the distal end, which was just shown beautifully by Mitch Wickard. So having done this, you have a suture coming up from one of the side, and then you just create a loop, pull the loop, and then the suture end is passed through the loop 4 times. 4 times is considered to be the most optimal because I went down into my lab and I just tested. Doing 4 times is just optimal. If you go ahead with 5 and 6, it still remains there, but it just adds bulk to the suture. So 4 was considered to be quite optimal, and that is how the technique derives its name as a single pass photocoupleplasty procedure. If you do these loops less than 4 times, maybe if it is 3 times or something, it tends to open up. The loops, they go loose, and then you might not get the kind of correction that you're actually looking for forward to. So in case if you're scared, you can take one more, but don't take one pass less than 4. 4 is just optimal. Having done that and having narrowed down the pupillary defect, you just go ahead with the non-appositional method. And this is beautifully described. You just have to use a double arm suture. These are the long, slender needle, which I try to use. These are the straight ones. I prefer to use a straight one needle for the non-appositional repair. And once you create the loop out there, you just need to suture it off, and then you can bury it into the scleral. Now, this is actually what I'm trying to show you is that wherever you find correctopia or anything, you can go ahead with a single pass photocoupleplasty procedure and gives you a perfect repair, which is combined by these 2 methods. And we call this as a two-fold technique because it combines 2 techniques together. So just running short of time, I'll just move ahead. Actually, this looks beautiful at the end of the surgery, and the pupil comes back to its normal shape. So another method that I just wanted to put forward was the trocar-assisted hangback repair. Actually, we just came up with this concept, because many a times the technique of iridodialysis, it fails because of the imbibement of the corneal tissue. Now, this aspect is common for any iris repair method. Whenever you pass a needle, it should not be imbibing any amount of corneal tissue. So this is a trocar-assisted hangback technique. In that, what we actually do, we just published this in the European Journal. So what we actually do in this technique is that you just put an anterior chamber trocar into the anterior chamber. You can even use a retinal trocar and place it on site, and you can pass on the suture needles from that trocar itself. So it does not actually involve this. In case if anybody has an issue with the usage of one separate instrument for this procedure, then what you can often do is that, what I often try to do is that I use a flat spatula kind of thing and place it at the paracentesis, and then try to glide the needle over it so that it does not involve the corneal tissue at that point of time, and then you can just do this procedure. So that's just an alternative in case if you really do not want to use another instrument, or if cost is an issue. So that can be taken care of that way. So here you can just see that this needle, it just passes through the barrel of this, and there is no chance of imbibement of the corneal tissue. So that's what this actually trocar assisted hangback technique is all about. So thank you so much for this. I would just like to put up this book which is coming up, our book which is coming up, and it will be there in the academy. During the academy time, it will be released. It's with the SLAC pupilloplasty techniques. If anybody is interested, they can go ahead, and all the masters of pupilloplasty, they have put up their chapters into this. Thank you so much.
So great. Next up, we'll have Ashraf Armia, and we'll discuss pinhole pupilloplasty.
Thank you so much for the kind invitation from Ammar, Priya, Ashwin, and in this prestigious meeting. I'm going to present in this presentation a technique I use nowadays in congenital colobomas, using two techniques of iris repair and one refractive procedure with the pupilloplasty. So the idea came really from Ammar and Priya give me the idea to use this technique. So this is a female patient, Syrian, age 36, came to me for refraction correction in her right eye. On the examination right eye, I found that she had an iris coloboma about 3 o'clock hours with normal.
Can you share your
Ashraf,
screen?
we are not seeing. Yeah, we are not seeing your screen, Ashraf.
Sorry. Is it clear now?
Yes, yes.
Yes.
Okay. So to use this technique, really the credit goes to Ammar and Priya giving me the idea to do this technique. So this is a female patient, Syrian, age 36, came to for refractive correction in the right eye. On examination, right eye, I found that she had an iris coloboma about 3 o'clock hours with normal posterior segment. Her psychophysical refraction was +7, sphere was -5 cylinder, with her best corrected visual acuity 0.4, with the maximum of +6 sphere and -4.5 cylinder. Her left eye was perfect with non-significant error refraction. So I asked for a pentacam for a femto laser correction. When I got the pentacam, I didn't become happy with this pentacam. There is a steepening of the cornea in areas in the anterior corneal surface, and also the posterior surface was not make me confident to go for a corneal refractive surgery. So I talked with the patient, and my decision was to put a high toric IOL with a pinpoint pupil as a visual correction with correction of the coloboma. So this is the video, and you see this is the coloboma. It's about 3 o'clock. So the most important in these cases, you are going to the refractive surgery mainly. So the rexus is very important to be central and circular. And also the CTR is mandatory in these cases to prevent any rotation of the toric IOL and make stability as much as we can. This is my idea. So I didn't only use the pupilloplasty, pinhole pupilloplasty only as a refractive procedure, but also I used the toric for more stability. But the technique of pinpoint pupil was very effective in this patient. You are going to see the results. The CTR, I put it, then I rotated to be away from the areas of the coloboma. to be aware, because this is the area of the Zenud's weakness. Then I use the high toric marking and using the high toric IOL. In this case, I was sure before I closed the pupil. And the very important in these cases, you find where is the end of the normal iris. If you did this, you are going to have a central pupil and regular. So this is what happened. I used the fourth through pupiloplasty, which is the marvelous technique now in pupiloplasty. Then, post-operatively, I was surprised after 2 weeks, the best corrector before the operation was 0.4 with +6 sphere minus 4.5 cylinder. But after 1 month, the best corrected visual acuity with the patient was 0.8 because of the two refractive procedures I was using with just no error of refraction post-operatively. So the idea of this technique, performing pinhole pupiloplasty, helps filter the stray light from the periphery of the cornea in cases with high order cornea abrasion. The pinhole blocks the distorted blood, reducing the abrasion, enhancing the visual acuity and its image quality. It was known that the pinhole devices mitigate the impact of the cornea abrasions with the pinhole visual acuity, but now we can say that we achieved the pinhole effect by narrowing down the pupil size. Use the Purkinje image, very important, helping to locate the center of the pupil. This is how you can achieve intractable high cornea astigmatism this way. Thank you so much.
All right, thank you, Ashraf.
Thank you so much.
Next, sure. Next up, we have Steve Safran. Steve seems to always attract complicated cases of all varieties, so we'll let him talk about complicated iris repair.
Can you see my screen?
Not yet.
Not yet.
I hit share screen. Okay. Can you see it?
Yes, sir.
We're good?
Yes.
Okay.
Looks
Okay,
like
great.
it.
All right, great. I'd like to talk about using a 33 gauge hypodermic needle to assist in iris repair for complex cases. In 1995, I started using a technique of using a sewing machine style iridodialysis repair, which was loading a 27 gauge needle with a tenoproline suture to do iridodialysis repair. And I did this for a while. This was kind of forgotten about. And then Kumar reintroduced this technique in 2013, and I think it gained a little traction. In 2018, I started using a 33 gauge hypodermic needle to assist in the repair of iris defects. And this is how I do these techniques now. This is a 33 gauge, 1/2 inch long hypodermic needle. The needle acts as a carrier to pass tenoproline through the iris. This has an external diameter of 210 microns, which is about the same as a CIF4 needle, and it eliminates the need for a needle holder, which gives you better control. So here's an example of how I do this on complex cases. This is a patient with the iridocyclectomy 30 years earlier. He's got a cataract, vitreous prolapse, and a large iris enzymal defect. He's missing about 1/3 of the iris tissue. There's not an iridodialysis and iridocyclectomy. There's a lot of tissue missing. So here's the case on the table. I've completed the phaco, the pars plana vitrectomy, and the Gore-Tex segment. I'm going to take my 33 gauge needle and bend it into a curve and load it with the tenoproline suture. I now pass the needle into the eye, and this acts as a carrier for the tenoproline suture. And I don't have to cross the anterior chamber. I can just grab the suture out of the lumen of the needle, pull this out. I now use a Kugel hook to pull the suture out the same side and do 4 throws, cinch the knot down, pull the knot into the eye, and I can directly tighten it and control the tension on it, and then cut it. Now, I'm going to do a few of these interrupted sutures to bring this defect down in size a bit, but I'm not going to be able to close it completely because there's too much missing tissue. So here's the second 4 throws, pull it into the eye, tighten it, and then the third. Each time I reload the proline suture into the lumen of the 33 gauge needle. And this is very fast and efficient because I'm not using a needle holder. I'm actually holding this directly. So I cut this short, and now I'm going to make another scleral groove and pass the 33 gauge needle loaded with the suture into the eye, through the iris, reload it, and do a running suture on the inside of the iris. I'll make about 3 or 4 passes here. Grab the suture, reload it into the 33 gauge needle, and now I will dock that 33 gauge needle into a 27 gauge needle, which it fits into the lumen of, pull that out, and tie this. And this will bring that iris over to the scleral wall as I tighten this. Now, when I do this, the pupil is going to be a little eccentric, so I'll do a hemicerclage, running the suture here on this side, about 5 or 6 throws, grab the suture, and when I tie this, it'll bring the pupil down very nicely. The patient looked like this 1 week post-op, and you can see it's a little eccentric. So I treated this with an argon laser on each side, and that rounded out the pupil, and it ended up looking like this, which I think is a nice cosmetic result. Now, I've used this technique to do full cerclage. This is a patient with a fixed dilated pupil and a dislocated cataract. That's after cataract surgery with a full cerclage using the 33 gauge needle. Here's a patient with a lens on the retina, cornea edema, missing iris tissue. Iris is very thin and frail. And this is after retrieving that lens, doing Yamani, doing a DSEC and an iris repair. Here's a couple of other patients where I've used this technique, the 33 gauge needle in complex cases. And this is a patient, an Iraqi war veteran with a very little iris tissue. It's atrophic and thin. And here I was able to do a cerclage with 2 iridodialysis sutures to sort of suspend his iris in space. So I just wanted to show this technique. I think it's a very useful technique. Thank you very much.
That was a great presentation, Steve, as always. We'll keep the discussion to the end so that we all and the panelists, we can have a discussion. So we move on to our next speaker. And Brandon is always great. Brandon, we look forward to your presentation.
All right, I believe that my presentation's already uploaded. Are you guys able to play? If not, I'll run it off my machine.
Admin, can you please play Dr. Brandon's presentation?
Yes, sir. Yes, ma'am. Yes, ma'am. We'll be presenting it. Yeah.
Hello, my name is Brandon Ayers, and I'd like to talk about the new artificial iris. These are my financial disclosures. And when you typically think about technology, you're not thinking about the artificial iris. You know, microchips, things like that come as technology, but the silicone artificial iris is certainly considered new technology, especially for eye care practitioners. Now, we're talking about the Custom Flex artificial iris, which has a color custom profile for each patient, although it takes about 2 months for that to be made. And it's available with a with fiber and without fiber version. Now, the difference is that without fiber prosthesis is much stretchier and it's good for bag, sulcus, or suture fixation to the scleral wall. The with fiber prosthesis adds the ability to suture an implant to the posterior aspect of the iris prosthesis. Now, let's talk about each of these fixation techniques. For in the bag fixation, you need an intact capsular rhexis. You also need to place a capsular tenturing, which has already been done in this case, and you're going to want to counterstain the capsule with Vision Blue. Now, counterstaining with Vision Blue allows better visualization for when the iris prosthesis is placed, as you can see here. Now, we're inserting this prosthesis through the Silver Series inserter made by Johnson & Johnson. You can clearly see in this case why the Trypan Blue is necessary, as it's very difficult to see the capsular bag and the anterior rhexis once the artificial iris is implanted, because you lose the majority of your red reflex. It's very difficult to get the entire iris placed into the capsular bag. Usually the leading third or so goes in with the inserter, and then the remaining portions of the iris have to be tucked into place using microforceps. Once it's in place, the surgery is basically completed. So here we needed that intact anterior and posterior rhexis. Intact capsular bag and anterior rhexis, a capsular tenturing in the bag, measure the capsular bag and put in your IOL, and then find and place your iris prosthesis. Here are 2 examples of patients before and after in the bag fixation with the without fiber artificial iris. Now, sulcus placement is even easier. In this case, there's no need for an intact bag as long as the the capsule looks to be relatively intact and it's not going to allow the iris to drop into the vitreous cavity. You'll again measure your sulcus space using an intraocular ruler, and then simply load and place the artificial iris into the sulcus space. Now, although this is probably the easiest technique, I still wouldn't call it easy, as it can be a bit challenging in some cases to get that artificial iris to tuck into the sulcus. So here the IOL's already in the capsular bag. We've got plenty of support from the overlying iris. Although if you needed to, you could suture fixate. And again, we're using the fiber-free design. Now, what if you have no support? Well, here you're going to have to plan on suture fixation, and it may be best to use the with fiber prosthesis. The with fiber prosthesis allows suture fixation of the implant to the posterior aspect of the artificial iris. We'll then use Gore-Tex suture to suture fixate the artificial iris to the scleral wall using a technique similar to what you would usually use for suture fixation of an IOL. Now you can see the obvious corneal edema in this patient. Our plan here is not only place the IOL artificial iris and then also do an endothelial keratoplasty. And the artificial iris does give an excellent support for the air bubble necessary for endothelial keratoplasty. Whether that's EK, DSEC, or PDEC would be up to the surgeon. These are the pre and post operative appearances of this patient before the surgery and now after. In summary, iris prosthesis surgery is very rewarding for both physician and patients. Multiple techniques may need to be employed for successful implantation. We now have this prosthesis FDA approved in the United States, and it is available worldwide, although it is somewhat costly, and it is a life-changing procedure for both physician and patients. Thank you for watching.
Well, that was a great presentation. I just have a question for Dr. Ashraf. Dr. Ashraf, how many cases have you done with your method of the case that you showed?
Yes.
How many times have you applied it in your clinical practice?
Yes, till now I have 5 cases with high intractable corneal astigmatism with the congenital globoma. So I am reporting these cases now upon publication soon, I think so. And the results the same. And why I used both the pinhole pupilloplasty with the high toric to maintain a long stability of the astigmatism.
That's great.
I have a question for Dr. Ayers. Great presentation. If you have a patient that has a coloboma, let's say inferior coloboma, intact capsule, and would you prefer to go in the bag, or could you place sulcus? Like, what is your fear with the potential of loose zonules or no zonules in a coloboma patient?
So we've had that issue come up several times, and typically with the coloboma patient, I'll try and do a primary repair of the iris first. But we've had a few cases where we think we're going to do an in-the-bag fixation, and we end up having to do suture fixation. And of course, you have to plan these surgeries well in advance because it takes about 2 months before you're actually going to get the prosthesis. So surgical flexibility is really a necessity in these cases. And the without fiber prosthesis can be sutured to the scleral wall. You just can't put an IOL on the back of the without fiber. So in cases where you end up with a surgical surprise, you have to suture fixate the implant first to the scleral wall and then separately suture the iris prosthesis. And I actually had that issue pop up while a news broadcaster was in the OR with me. So you got to keep your cool during these cases.
Brandon, I have another question.
Okay.
Yeah, Brandon, aniridia patients are people that come to mind immediately for these iris prostheses, but I think they present some challenges. Could you just speak a little bit about the challenges and issues you've run into in that population?
Well, the aniridic patients are probably the most challenging because you're never really sure what you're going to be dealt. They have thin capsules, they've got zonulopathy, they've got the aniridic stem cell deficiency, they've got retina and macular problems. And so these are the cases where you really have to be ready to do anything. And in fact, one of my first cases was an aniridic patient. where I was planning on an in-the-bag fixation, had to quickly change because the zonules just were not strong enough, not even to hold the implant. So we had to do a vitrectomy and then suture the IOL and iris. I've also had spontaneous tear-outs of the anterior rhexis, in which case I had to convert from an in-the-bag fixation to a sulcus fixation. And in an aniridic patient where you really have no iris tissue, I don't think that passive fixation is going to work. So we had to use polypropylene suture to fixate to the scleral wall.
Dr. Brandon, great presentation. Just one question on the follow-up. Do you face a lot of increase in the intraocular pressure with those artificial iris? And if yes, how do you manage it?
So the intraocular pressure rise depends on the case that you're given. Traumatic cases, aniridics, when you're placing the artificial iris in the capsular bag, I don't think you're at any higher risk of seeing glaucoma than you would if you were doing glaucoma surgery, cataract surgery. So we don't really see much problem in straightforward cases. The problem is in cases where you have high PAS, patients have pre-existing glaucoma or unstable glaucoma. There, yes, the pressure can go up very quickly, immediately, in fact, after the surgery. So you have to have a long discussion with those patients about the glaucoma. And certainly the best plan is be prepared and have the glaucoma managed prior to implantation of the artificial iris or at the same time as the artificial iris. So a combined iris surgery with a tube shunt or a CPC laser or whatever the case may be, I think would be advised. But you treat them like you would any other elevated pressure, topical drops, Diamox, mannitol if you have to, and of course incisional surgery also.
Dr. Pal, would you like to put in some of your some opinion regarding all the presentations? Yeah, we'd like to hear from you.
I think they're incredible. So much has been done with the iris and the pupil. We know that it's important for photic symptoms, for cosmesis, and for vision and presbyopia. And now we're going to enter an era of using drops for this in the United States, just electively. Steve and Priya, how do you guys know? You guys are taking on some big iris defects with repair. Are there ones where you say, you know what, I'm not even going to bother? Steve just showed one where it was a third of the iris. When do you know when to go with the prosthesis versus primary?
Are you asking me? Yeah, if you have, it's funny because, I think if you can preserve the iris, natural iris, it's worth a shot. If it fails, you can always go back and put an iris prosthesis in. So I've had a lot of cases where I looked at it and said, I don't think I'm going to be able to fix this. And then, you do it and you say, hey, it looks pretty good. The patient's happy and they get to keep their iris. So it's actually cut into my ability to find cases to do iris prosthesis with, because I find, I'm often able to fix these things. They unfold on the table and you say, that's not too bad. I think we're pretty good with this. And, it's really like a shuffling game. You're trying to move iris from here to there to create a pupil. And if you have a defect under the lid somewhere, it's usually not so terrible. But very often the iris is curled up, it's folded under itself. You can stretch it out. You can do something with it. If you don't have any tissue, if the iris is, mostly missing, if it's all atrophic, if it's tattered, then obviously you're not going to be able to do that much with it. But it's surprising how much you can do in a lot of these cases.
Absolutely. My thoughts also resonate with this. We try to preserve as much as the normal iris tissue is there. And I think the best thing is that when we try attempting doing a pupilloplasty or a major iris repair in these procedures, actually you really get a feel of the flexibility of the iris tissue, and you will actually immediately come to know that whether you will be able to do it or you won't be able to do it. If you are not able to do it, anyway, you have processes with you. But yes, if you can do it, and if there is a flexibility and you feel that you can fix up the defect, it really works well.
And I think it's important to mention that there are complications with the iris prosthesis. It can, with the natural iris, you don't have those complications. And, you can get the illusion of having a normal eye with what doesn't look so great at the slit lamp, but it looks from 3 or 4 feet away, it looks really cosmetically quite acceptable.
One last point, there's another iris prosthesis being used around the world, bright ocular. I'm wondering if you guys in India have seen problems with that. And we know Brandon and others have actually used the human optics to repair problems caused by the cosmetic broad ocular. You guys seen that in India? We have patients in the US traveling to Asia to get this done. Well, Brandon's seen it.
Yeah, we've seen several cases of the cosmetic iris prosthesis needing to be removed, and even then requiring the human optics iris prosthesis for repair.
Yeah. We do not have it in India. We do not have that yet.
We don't have it in the United States either, but people go and get it and then come back with the problems.
Yeah, this is not an approved product. That's why I want to make sure there's a distinction.
Yeah. Can you suggest what would be the price for that? Like how much approximately is the price for that?
One eyeball is pretty much the cost is.
Yeah, exactly. One eyeball. Because they require about 4 surgeries afterwards. It's a big problem.
Dr. Priya, can we wind up? I think, Dr. Priya, you're muted, Dr. Priya.
Oh, sorry. Yes, I think we need to end
We've
the
got
session.
Deependra Dhaliwal also on the stage with us. Deep, can you give us some opinion on your points on the pupiloplasty?
I would be happy to. Good morning, everyone, and good evening. I want to just congratulate all the speakers. They've done an amazing job, really kind of breaking down this complex topic into simple approaches. But I want to congratulate Dr. Amar Agarwal, especially for really simplifying a pupiloplasty technique. The 4th row pupiloplasty is so simple because you can just do a single pass. And I think that's what we all should start with. We should start with that technique. It's very simple, and we should really start, step by step before we can conquer these very challenging cases. So I think master one technique, get that under your belt, and then proceed with these more complex cases. So thanks, everyone. I think that was a fabulous session. Thank you.
Alain, what about you, Alain? Some few tips you can tell us?
Well, it was an amazing session, and most of what needed to be said was said. In my hand, one of the difficult things was the centration. So trying to do those sutures and ended up with a nice, well-centered pupil. And I really like the presentation done by Dr. Mitchell, who showed really how we can, after putting our suture, if we end up having a pupil that is not perfectly centered or a little bit decentered or an ovalization, we still can readjust and recorrect it. And this is also very, very helpful.
Can you close up, Priya?
Yeah. I think this was a wonderful session, and thank you all for being here. We have time constraints, so I think we need to end up this session, but it was really wonderful having each one of you. Thank you so much. Thank you so much.
Thank you very much, Mitch.
Thanks, everybody.
Thanks for having both of you for the session, all of you. I request all of you to just exit from the system there, because we'll be moving on to the next session. Admin, can you have the ad on now?
Yes, sir. Yes, sir. We'll have that.
Well, good evening, good morning, good afternoon, depending on the country you're in, everyone. Again, welcome once again to this session of the IIRSI. We are going to have 2 great people who are going to moderate this next session, and they are none other than the president of the AIOS, the chairman scientific committee of IIRSI, that is Dr. Mahipal Singh Sachdev, and Krishna Prasad Kudlu, who's such a dear friend and what a great organizer for conferences. Mahipal, over to you.
Thank you, Amar, and welcome all of you. Welcome the moderators, the panelists, and the speakers, and obviously the delegates who are attending from all over the world. This session, though is 2-minute topics, but actually we are giving you 4 minutes to present them, and they are mainly going to be small little signs and tips that everyone is going to give, mainly video based. And Dr. Krishna Prasad, as you all know from Udupi, hope you are fine. Saw on the television a lot of rains there. Krishna Prasad, all good?
Heavy raining, sir. Half the city is totally inside the water.
Okay. We hope that
Hi,
all of
Kritik.
you remain safe. So we have in the panelist, we have Devashish, who's a past president of All India Ophthalmological Society, and he runs efficiently the Disha group of eye hospitals. Devashish, always a pleasure to have you. Great master, great thinker, I would say. One of the people I always do my, if I have to go back and seek an advice, Devashish is one of them. Dr. Barar from Kotkapura, he is somebody who's really excelled and does a great amount of cataract surgery and refractive. Dr. Arun Jain, a close friend of mine, we were together at RP Center, a product of AIMS RP Center, and then he's just now the director professor at PGI Chandigarh, a great anterior segment and cornea surgeon. And finally, somebody, as I would say, Bhish Pitama of refractive surgery, Sudhang Bharti. He's been at the forefront of refractive surgery in India, and from Agra, and just now practicing in Delhi. So without much ado, we'll go on to the 2-minute topics, and that's the various signs. And the first person I love to call on is dear friend Rohit Om Prakash's son, Tushya Om Prakash, budding rising star of Indian ophthalmology, doing great job as making videos, has won the awards at IIRSI, and he's going to talk about something which we all would love to hear, and that is the flat motility sign for cases where we are suspecting an extension of posterior of a rent going posteriorly. Tushya, all yours.
Thank you so much, sir, for the kind words. I would like to share my screen. Can you see my screen?
Yeah, you can start, please.
Okay. First of all, I would like to thank IIRSI for giving me this opportunity. Today, I'll be talking on flap motility sign for posterior capsule rupture in peripherally extended anterior capsular tear. So let's see what happens when there is an Argentinian flag sign. The surgeon is always in a dilemma whether to continue phacoemulsification or to convert. As we all know the classical signs of PCR, they have their own shortcomings. They do not appear instantly. The time lag for recognition of the sign varies according to the expertise of the surgeon. So here, everted and fluttering flaps are pre-equatorial tears. But once this tear extends beyond the equator, it stops fluttering and becomes inverted. So this is a classical case of white intumescent cataract with an Argentine flag sign. Here, I would like all of you to focus on the trypan blue stained anterior capsular tear. It is everted and freely fluttering. What does that mean? It means 100% the flap, the tear is pre-equatorial in nature. So this gives us full confidence to continue the surgery with safe phacoemulsification techniques. This is another case where one of our residents was trying to enlarge the rhexis and it resulted into an anterior capsular tear. The surgeon was oblivious of the fact of flap motility sign and kept continuing phacoemulsification without realizing that the flap had stopped fluttering and lied flat. So there was a nucleus drop. Flap motility sign helps in deciding the site of IOL implantation. Everted and fluttering sign flap is conclusive for IOL implantation in the bag. It helps us to know the endpoint of safe phacoemulsification. In this case, when the flap had stopped fluttering and lied flat on the nucleus, it was the endpoint of safe phacoemulsification. It helps us to, flap motility sign can be ascertained with the injection of viscoelastic in the anterior chamber and observing the nature of the flap. It is confirmed by the introduction of fluidics in the anterior chamber and observing the nature of the motility of the flap. This sign is now a published sign of posterior capsule rupture. Thank you.
Thank you so much, Tushya. I think it was a fantastic presentation, but a lot of take-home message was there, like as Mahipal sir was telling. Just I think, shall we have the discussion in the end, sir, or shall we finish each case by case?
I think we can have a 2-minute discussion after each. Dr. Devashish, you wish to say anything about the flap motility sign, or anybody, Dr. Bharti or Dr. Devashish?
No, I can just congratulate Tushya for a wonderful, honestly, it's a learning. And obviously, I mean, if we watch the visco when we are in dilemma and see the flap motility, I think it gives us, it is a very good advice that it gives us a clear idea whether it has extended in the posterior capsule and there is a PCR. Thank you, Tushya, for this wonderful tip.
Thank you so much.
One question from my side.
Yes,
Just
sir.
will you able to tell what exactly, whenever you notice this kind of rhexis extension or whenever rhexis has cut, what is going to be your phaco settings in these cases?
So I usually follow safe phacoemulsification techniques. I reduce my IOP, I reduce the parameters, phaco parameters. And then when I continue my phacoemulsification, I make sure that when I'm dividing the nucleus, it is the action of division of the nucleus is in the line of tear rather than 90° to it. And secondly, I can do supracapsular nuclear emulsification. I just have to follow all the safe phacoemulsification techniques to make sure it doesn't extend.
Thank you very much. Ram, do you want to make a quick comment and then we go on?
Just a very small comment. This is a wonderful sign. This is a wonderful observation by Tushya and then Rohit. And I personally feel that all the residents should be taught very clearly that this is the first sign where you want to convert, enlarge the incision and take the nucleus out without going ahead and doing further phacoemulsification, because then the chances of dropped nucleus are very high, because it's already extended beyond the equator. So this is a very good sign for the residents to observe, and it's a warning kind of thing. Thank you.
And thank you very much, Dr. Sudhank, and thank you very much, Tushya.
Can I make a comment, Mahipal?
Yeah, Arun, go ahead.
Yeah. Congratulations, Tushya. Great video. But just one comment I want to make, especially for beginners. Once you notice this sign, as in your video, the second video by a resident, he made a groove and then separated. That should be avoided. Separating in the direction of this tear should always be avoided, because that will enlarge the tear and it will go around the equator of the bag and go into the posterior capsule. Only that comment I wanted to make, that is to be avoided. Either you do a supracapsular as you suggested, or one can do a vertical chop and avoid separating the nuclei in a horizontal manner. Thank you.
Thank you very much. I think the basic take-home message is that this is one of the signs to let you know whether it's got extended, but otherwise, whether you lower the parameters, do supracapsular, etc., that will all be there once you have an extension that is there. We go on to the next speaker, none other than Dr. Chitra Ramamurthy, who is the chairman of the IIRSI in All India Ophthalmological Society. She's a director at the Eye Foundation, and she's, as you all know, a great cataract refractive surgeon. She's going to talk about IOL scaffold. All yours.
Thank you very much, Dr. Amar and IIRSI, for this wonderful opportunity, and congratulations for a great show. So I go on to this IOL scaffold. Now you can see it's a circumscribed PCR. There's no vitreous presenting, and there's just this small chunk of epinucleus. Now it is quite possible to have actually taken care of the small piece of epinucleus, but I decided that wouldn't take a chance at this point of time when there was no vitreous presenting, and I needed to place my single piece IOL in the bag. I could have made it convert into a PCC, but this was a circumscribed PCR, so I didn't do that. I just teased off that very little cortex with very slow flow parameters, and then went back to deal with the epinucleus. So I had IOL as a scaffold here, and this ensured that there was a much greater comfort zone to get rid of the epinucleus. At the same time, this single piece IOL was tamponading the vitreous from coming forward. Of course, the parameters have to be kept low, so you do not want any anterior chamber shallowing. And then a very gently removal of the viscoelastic was done. And of course, we need to be careful at all time points, even hydrating the wound. You hydrate, keep one instrument inside, and then go on to hydrate the second wound, second opening. Now, this was a second case when suddenly there was an anterior chamber shallowing and the nucleus dropped. There was a subincisional PCR, and then it was all jugglery about getting this nuclear fragment up. The good news here was there was no vitreous presenting, so very well managed to get the thing, and then injected viscoelastic, dispersive viscoelastic under the nucleus and above to protect the corneal endothelium, and then enlarged the incision and injected a 3-piece IOL. Now, if there is a large chunk and you're not able to visualize as too much vitreous, you could place the haptics on the iris itself, because at this point of time, it was to act as a scaffold and need not be placed in its original place. But in this particular case, I did manage to place it in the sulcus. Again, brought down my parameters because it's important and there should be enough viscoelastic to coat the endothelium, and thus got away with doing it. Now the vitreous had to be taken care of, so went behind the IOL, removed the vitreous and the cortex which was there. Again, found this vitreous strand and then cut the vitreous in front of the IOL. Injected triamcinolone to know whether there was any aberrant vitreous strands which were present. And then once it got done with this case. So it was another second case with the IOL scaffold magic of Amar. This is the third case. Now, this was a hypermature cataract with calcified spots on the thing. So there was a good possibility that there would hardly be any epinucleus and it's going to be a floating nucleus which had to be dealt with. So, but sometimes you are able to deal with the case, and it wasn't a particularly very dense cataract, but this is something we need to anticipate, and you could see that the turbulence was created and I was not able to get a purchase of my phaco onto the nucleus. So this is the time when naturally I would have, as earlier, I would have brought this nucleus fragment up and then do a supracapsular phacoemulsification and compromise the cornea. But now, not just the cornea, compromise the chances of a posterior capsular rent happening here because of the process of phacoemulsification. So then now in this particular case, IOL is well seated into the capsular bag. And then, of course, if it had been a hard nucleus, it would have been a bit of a challenge. It was a fairly moderately hard nucleus. So with the dispersive viscoelastic protecting the cornea and with the parameters kept low and very slowly and carefully, this nucleus was emulsified.
I think
Dr. Chitra's connection has gone.
I think connection is gone. Okay. Thank you very much, Dr. Chitra. Dr. Barar, you want to say anything on the compartmentalize? You need to unmute yourself, Dr. Barar. Unmute.
Yeah.
Dr. Barar. Yeah.
Hello, good evening, everybody. Dr. Chitra showed us beautiful presentations. Especially second and third case were very understandable. I wanted to ask, what made you put your IOL in your first case into the bag? There were chances of PCR getting extended unless and until there is a very good posterior access that has been done. I mean, my thinking was that you could put it into the sulcus and do all your maneuvers, because whatever you did, there were chances of PCR getting extended. What is your view on it?
See, it was a circumscribed PCR and there was no vitreous presenting. So it made sense that the plan of action was a single piece IOL in the capsular bag. So I very gently, it is a challenge to place a single piece IOL because I had not converted into a PCC, but they were all rounded off edges. So I placed the single piece in the bag, and this was tiny piece of epinucleus. So I decided that with the IOL placed, I could deal with the small piece.
In that case, I'm sure you must have kept your parameters while removing the epinucleus very low.
Yes.
Yeah.
Thank you, madam. And it was a fantastic presentation, madam. Just one small question from my side that in the second case, I think you could able to almost the nucleus was half the nucleus. Then you could able to put the lens in the sulcus and you continue. Did you had any experience? Sometimes what happens, you try to fish around the nucleus and already you had put the lens and intraocular lens and the piece of nucleus is within the vitreous cavity. Sometimes you cannot get the nucleus onto the intraocular lens. Have you anytime tried this PAL, posterior assisted levitation, any of in your cases, madam?
No.
To get
Yeah, thank you very much. I think we need to, we are already at 25 minutes past the session and only 2 speakers. We'll go on to, thank you very much, Dr. Chitra, for an excellent presentation. We go on to none other than Kumar Doctor, one of the finest surgeons India has ever produced. He's a great cataract and a refractive surgeon, and he'll be talking about certain facts about glued IOL. Over to you, Kumar.
Are you able to? Thanks, Maipal, and thanks IIRSI, Amar, Maipal, everybody to have asked me to participate. Can you see the screen now?
Yes, please start.
Okay. So this was a case which came to me with operated by me only 20 years back, and the lens was in the mid-vitreous. So now I'm on the topical. I'm not going to do this on the topical, but I was just checking and moving the eye, and you can see the lens coming and going. The patient has been blocked. Now the question here was, what lens is it? We were trying to see it, whether it's got haptics and what is the way out. So here we decided that first we explant this lens and put in another glued IOL. That was the strategy. Now this, don't forget that this was operated almost 15 to 16 years back by me. So first we decided that let's prepare for a glued strategy here. So made two side ports, made the flaps for the glue, and then decided to do the vitreous, which was vitrectomy, which was there present in the front. And as soon as the vitrectomy started, the lens itself came up. And so to avoid traction, we did a little more of vitrectomy around and got the lens out. So now you can see this is an old lens with 4 dialing holes. This was a 6.5 millimeter optic, a modified J kind of a lens, which was there 15, 20 years back. Once this was done, I'm holding on to the lens. I'm supporting it with the iris suppositor and getting it, making sure that it doesn't fall back, and make sure that the whole lens is brought out into the AC in front of the iris. So we can see that the whole lens is now out in front of the iris. But at this stage, I want to now think that it's a modified J. So we have two options. And here what I'm doing is, you can see that the J is inverted. I flipped the same lens in the AC to make the fixation of the same lens in the glue part quite easy. So now this is the right position to be in. There were two options. Either I remove this lens and put in another one, either a sensor, which is the most ideal one. But then I thought, why not use the same one? So then go ahead and do all the other techniques as taught by Amar and followed by us as always. Now we got the, so I'm doing the whole procedure through two side ports, 0.75, the same lens. There's nothing to worry about measurement because the patient was very happy for so many years. So there's no botheration about the measurement, just the handshake technique, get the haptic out once the haptic is out. And this was a modified J. So these are huge haptics. So we are really not worried about this falling back. That's another big advantage. And once you got this, make sure that we get the other haptic in front. And again, the same handshake technique. Once that is out, again, you can see that the other haptic is out. So then we just center the IOL by tucking it and then constrict the pupil. So the IOL is very well centered. So through two side ports, a dislocated IOL in the mid-vitreous can be brought back into the AC and then refixated, not worrying about anything else, and hardly any manipulation happening at the level of the anterior chamber. So there's no need to explant that lens. We were able to refit it. Of course, it was, if it was some other design, then we have to explant and reimplant a 3-piece IOL. So here, just going ahead and doing exactly what Amar has taught us for so long, and then just putting pillow carp in and putting air and making sure that the chamber is well formed. So to two side ports of a 0.75 millimeter, we finished the whole surgery. And of course, this patient did extremely well because there was no IOL calculations necessary at all. And this is just making sure that the glue is placed all over because we are preparing to explant this IOL, not really knowing what was there. I'll try to stop my sharing here.
Brilliant.
Thank you, Maipal.
Thank you so much, Kumar. It was a fantastic presentation. Any comments from our panelists? Or shall we go ahead with the next presentation?
Yes, we'll go on to with Priya Narang, who's also done excellent work on glued IOL, but this time she's coming out with a new innovation that is the advanced vision analyzer. And I have had the opportunity to get it used in a couple of our patients, and I think it's a great device for home vision analysis. Priya?
Good evening, everybody. I hope my presentation is seen.
Everything is good. You can.
Yeah. At the outset, I'd like to thank Dr. Amar and Dr. Maipal for this wonderful session. Well, I will be covering up the Advanced Vision Analyzer. We call it as AVA. So basically, this is a virtual reality automated perimeter, and it has 4 basic components, which is the head-mounted device. It has a patient response button that you see on the left side. It has a test control device, which is a tablet, which is seen on the right side. And there is a backend server. We call it as a cloud. That stores all the information of the perimetry that is done for all the cases around. So the key features of AVA are that it offers white-on-white perimetry. You have an option to correct the refractive errors of the eyes that you are testing. The interpupillary distance can be adjusted. It has a wonderful eye tracking subsystem, which has 2 infrared complementary metal oxide semiconductors, and it has infrared LEDs, which is used to illuminate the pupil of the patient. The stimuli that is presented in AVA is the Goldman standard size 3, although there are other options also available too. And to ensure a reliable test, the best thing is that there are catch trials. And these catch trials are incorporated, and they play a very important role into checking for the false negative, positive, and the fixation losses that we always look forward to the reliability parameters in any perimeter, any perimetric report. AVA has a cloud-based storage system, which I told you before. It's a backup of all the tests and the report information that you have done. And the best part is that you can have all the data recorded, and from there you can retrieve the data whenever you need it, and then you can just email it to any consultant or to the patient or anywhere across the globe. So we're running short of time, so I'm not running that video, but I'll just tell you briefly that this device, it has 30-2, 24-2, and a 10-2 program, which is incorporated into this. And the algorithms which are there in the device is the ELISA fast. Now, and the ELISA zest and the full threshold. All these algorithms are in sync with what we are commonly used to. ELISA fast corresponds to the Humphrey CETA fast. The ELISA zest is like CETA standard, and the full threshold program, which is always there incorporated. Although all these algorithms are specially designed for the device AVA specifically. So this is just a brief review of the perimeter reports that the device it shunts out. You can compare it with the Humphrey perimeter. It's almost similar with the mean defects and the global indices and the reliability parameters coming up. So the similarity is quite much good, and it's very good for the detection of the visual field effects. We have done quite a couple of studies on this, and we're just waiting for peer publications to come up on this. The ongoing development that we are working on the devices for the progression analysis and the EMR integration. Once this comes into the device, it becomes totally complete. The advantages with this device is that it is portable. So this is a very important advantage, because you do not need any specific dark room for doing a perimetry for a patient. You can even do it in any of the rooms. You do not need any specific space. The learning curve is not there. It's anybody who is used to doing other perimetry tests is just the same. There's an accurate detection of visual field defects. We have done quite a bit of studies on this. It's cost effective. It's almost 1/3 the cost of a normal perimeter that comes up in the market right now, the standard automated perimeters, what we call. It's especially useful in screening, especially in the rural areas, and it gives a lot of postural freedom. You can even do it in, you can even do a perimetry in patients who are, who are bedridden, who cannot sit, who are neurological cases. So it gives you a lot of postural freedom, and specifically, the greatest advantage that it has in this current situation that we all are facing in the world is the pandemic, where you can do a perimetry test with this device with a face mask on. So it gives you a lot of freedom, and it gives you a lot of mental peace when you're doing it, because you're not directly exposed to the patient. The patient can wear a face mask and then do it, because it's a virtual reality perimeter. The patient just has to wear the virtual reality device on the head, and then it goes off. So I think these are a few major advantages with this device. I think with the time constraint, I'd just like to wind up on this. Thank you so much.
Thank you very much, Dr. Priya. Any comments from any of the panelists? Do you have normative data on this?
Yes, there is a normative data which has been fed into the device. Yeah.
Okay. Anyone has any comments to make? I think we have done in few cases, and it is giving comparable readings as with the Humphrey.
How much is the price, sir? Price? How much is the price, sir?
She will give it to you for free. All the moderators are getting
around 2.5 lakhs, no?
I'm not going to comment on the price.
I think it is very
it's fine. But are the pattern deviations and the other comparative modalities, I mean, all the strategies have been as per the Humphrey parameters? Priya?
Yes, sir. It is the glaucoma hemifield test. We have done the specific analysis of the entire 10 sectors which have been basically considered, and we have compared the mean sensitivity along with the mean defects and the pattern standard deviations, and it is there's absolute substantial equivalence with the Humphrey. Yes.
But don't you need to have a standard pupil size? You say you can sit anywhere and do it. Pupil size is so critical when you're doing your fields. No, I think. No.
Oh, does it has also
Need to
the
sit in one
sorry.
room.
I think you're wearing a virtual reality headset, like I mean.
You're wearing everything, so there's light.
Yeah. So there's no light coming in.
So does it have also the
I didn't show that video of the Ava because we had a limited time. Otherwise, that video was actually showing how to wear the device, and you have a patient response button where you click it. So it's just like that.
Can I ask one question? Yeah. Does it also have a glaucoma progression analysis software also? The long-term progression.
That's what I just came up to. That is being integrated. I think within the next 2 or 3 months it will be there. The progression analysis also.
So I think
we are about to acquire it at IIRSI Center. It is a great tool, especially in the COVID times, because getting that perimeter bowl to sterilize is very difficult. But this, because it is present only on the eyes, the sterility is, can be done much easier. So in the COVID times, it is a great tool to have.
And it's portable. Where is it portable? And it should be very patient friendly, because the old people, they get so scared doing that perimetry. Most of the people refrain from doing the test. I think this should be very good.
Absolutely. You can do it in reclining or in a semi-reclining position, whatever is comfortable to the patient. Yes.
And I think the price that they quote around is 3.5 lakhs, and the rest you can negotiate.
Where is it available?
It's available, I think. The company is available.
Yeah, the laser vision technology has it.
Vision.
Yes, the laser vision technology. I'll send you the contact number.
Okay, thank you very much.
Give a discount also, Priya.
Sorry?
Pardon?
Priya, you give a discount also.
Complimentary. Okay, anyway, thank you very much, Dr. Priya. Excellent presentation as always, and I hope that this is going to make the field analysis something much simpler. We go on to thank you. We go on to Dr. Namrata Sharma, Professor of Ophthalmology at RP Center, and I think she's doing wonderful academic work, as also one of the hardest working secretaries I have seen in All India Ophthalmological Society.
Thank you, sir.
She makes people videos and academic. She has lots and lots of publications. Maybe 300, 400. I'm not sure, but every other week or second week she has a publication. So she'll be talking about PDEC. Namrata, all yours.
Thank you so much, sir, for kind introduction. When it comes from you, it makes a lot of difference. Thank you, Amar, for organizing this conference, for having me here, and for more importantly, for describing this technique of PDEC. There are no financial or proprietary interests, and basically it has stemmed from the fact that pre-Descemet's layer is also taken into the endothelium, and so it becomes thicker. It is basically the pre-Descemet's layer with Descemet's membrane and endothelial complex, which we are going to transplant. It has a splinting effect. It has expanded the pool of the donors, so young and diabetic donors may be used. It is much easier to handle. And now you can even use infant donor corneas for DMEC, which earlier you could not, because for DMEC, the important thing is that the donor age should be more than 40 years. So these are some of the articles which state that PDEC can be done with infant donor corneas, and these are the differences which I have already talked to you about. The scrolling propensity of the PDEC graft is less as compared to Descemet's membrane, so the handling becomes much easy, unfolding becomes much easy, and even harvesting is much easy. So this is just to show how we do it. There is a big bubble which is created from the trabecular meshwork using a needle which is 26 gauge, and on the IOCT you can see that there's a bubble which is there. Then following this, the trypan blue is injected, and after injecting the trypan blue, this edges of the bubble are dissected so that you have a graft. Now this graft essentially consists of the Descemet's membrane and the pre-Descemet's layer. And if you compare it with the DMAC graft, it appears to be thicker even on the intraop OCT microscope if you compare the two together. And this is then put into the media, such as a cortisol media or a MK media. Now, subsequently, this is a case of pseudophakic bullous keratopathy. So the hypertrophic epithelium is removed. There's an inflammatory membrane which is present there, which is also removed. And then desmetorex's scoring is done. And the diseased Desmet's membrane is removed with the help of the reverse Sinskey hook. It is important to ensure that the entire thing comes out. This is the PDAC graft which had been initially harvested. This is injected into a glass tube and then injected intracamurally inside the anterior chamber. And then this is placed centrally. Important thing is that you cannot do the same work which you do in a case of DMAC. So it has to be manually placed over an air bubble. And the PDAC graft now gets attached to the back of the cornea. So if you see, the results are pretty good. This is almost a 700 plus micron cornea, and then over a period of time, it does decrease. It takes time to clear up, and it takes time for the detergence of the cornea to occur. So these are just some of the cases which were done by PDEC, which look very clear, and we were comparing, in fact, PDEC with DMEC, and these are the results of the PDEC graft with visual acuity of 612, 618 in most of the cases. So this is just to show the same. So thank you very much for your kind attention, and PDEC has increased expanded the pool of the donor corneas now that we can use for our endothelial keratoplasties.
Thank you, Namrata madam, for a wonderful talk. It was really amazing talk as usual. I think any comments from our panelists, especially I just need to take some opinion from Dr. Arun Jain. Any comments?
Arun, you're muted. You're muted.
Yeah, a very nice presentation. The Dua's layer description has made the things much easier for us. And the handling, as she has already highlighted, the handling of the graph become much easier. So maybe, and as she also said that the pool of the donor endothelium has also increased. Now we can use younger donors for endothelial keratoplasty, and maybe this is the way to go for the beginners to start with the Desmet's membrane endothelial keratoplasty. Yeah, very nice presentation, Dr. Namrata. Congratulations.
Dr.
Thank you.
Namrata,
yes.
Dr. Namrata, I mean,
yeah,
if he's not a young donor, do you actually get a PDEC clinically or surgically? Is it available every time?
PDEC you can do with any age. You can do it with a young donor. You can do it with an old donor. It doesn't matter. But for DMEC, this is a limitation. We started doing PDEC for this reason, because we got a lot of young donors, but there were patients who were waiting for DMEC, and scrolling is a problem. That you get very tight scrolls if you use younger donors. And in DMEC, it becomes difficult and a struggle to unfold those and center them.
Suppose you have overcome that you can actually do it. So I mean, which one would be the surgery of choice for endothelial keratoplasty? DMEC or PDEC?
I think the results that are coming, and we are actually doing a randomized control study to see. So both of the techniques are comparable with the additional advantages of PDEC that have been mentioned.
Thank you very much, Dr. Namrata. Because of paucity of time, let's go on to the next two speakers, the last two speakers. We have Dr. Meenu Mathan. He'll be talking about Trocar AC maintainer, a very efficient, proficient surgeon from Trivandrum. Dr. Meenu, please go ahead.
Hi, sir. Am I audible?
Yes, please make it full screen. Yeah.
Yes. So thanks to Dr. Amar for this invite on talking on Trocar ACM. As we all know, he has published this in 2016. And we need an ACM when we do, as I'll be sticking on to glued IOL cases. So they come in different sizes and shapes and all, so sometimes we need to extend it. And for me, people like me who are not regularly using this ACMs, we do not know exactly what is the size. Sometimes it becomes smaller and you have to squeeze it in, you cause DM detachments and damage there. Sometimes it becomes a little larger and it just comes off during the surgery. So that is why we think of a trocar and a cannula, which we regularly use for the VR surgeons. And I am again not a trained VR surgeon, so using this also has a slight learning curve. So using this for a glued IOL, so we are using this as 25 gauge one. So go 45-degree at an angle of 45 degrees to the limbus, not exactly into the clear cornea, and then once the tip is inside, turn 90 degrees inwards and then push the whole thing inside. So once the trocar fully goes in, the cannula is also in, and once this is flushed to the limbus, you remove the trocar and then fix up the infusion. Once that is in, towards the end of the surgery, we can just pull it out and then it just comes out, and once for few seconds if we close it off, it just stops and it is it closes by itself. This is again showing a corneal incision. You can go through the cornea also, but here the turning towards the center of the eye may be a little difficult, and so because this being very large, it is little scary and it may touch on the angle structures or on the iris. And so in this case you can notice that I have not fully gone in, but the tip of the cannula is inside. So once that tip of the cannula is inside, I take out the trocar and then push it in. So here again, we can make a slight, and then this can be just pulled out, a little bit of hydration, it will also close. It need not be a stab entry. 1 millimeter, you can go through the cornea and then enter into the AC. And some cases, I close all the incisions with glue, and this case also closes with glue. Otherwise, also it will close. But here, what you can see is, this is the length of the trocar, and this much is the cannula, and the trocar is too long here inside this. So we can make a Mastel makes a small one which is available for this one, but if we want to use our regular ones, we can make small modification on this. We can use these kind of silicone bands cut into smaller bits, and initially use another trocar and make a hole inside that, and then put it into the trocar first, and then thread in your cannula. So then now you can see that the tip of the trocar which is outside is very small. So you can go into the anterior chamber very easily. And again, I gave one of these old ones to our biomedical engineers, and they cut the trocar cannula off the head of this one. And this is the additional separate one which you first load into the trocar and then put in the cannula. Again, you will have a small part of the trocar outside. And so this kind of small modification you can make, and it will make safer. So the main advantage, biggest advantage is that it is a self-sealing, and it's a tight fit, very atraumatic, and it stays on without the risk of coming out during the procedure.
Brilliant.
Thank you, Minu, for an excellent innovative video. I think let us come to the last part of the presentation. One of our genius cataract surgeon, most respectable, none other than Dr. Suhas Haldipurkar from Panvel, Mumbai. I think he'll be talking about us with pinhole pupilloplasty. Over to Suhas Haldipurkar, sir.
Thank you so much, Dr. Kudlur. Is my presentation visible, sir?
No, Suhas, nothing.
No?
No.
No?
Oh.
No. Till he gets his presentation on, Dr. Devashish, I think you are also very fond of the ACM and also the role that I think.
Yeah.
Okay, go ahead. Yeah.
Yeah. Thank you, Maipal. This presentation, of course, has been done today and yesterday once too many times. But since it's a 2-minute procedure, pinhole pupilloplasty is the subject that I have to speak now. Pinhole pupilloplasty, array of hope for aberrated cornea. A technique becomes a landmark procedure when it is simple, easily doable, and essential in a group of desperate cases. In fact, a 4-throw single pass done several times over to give pinhole pupil is one such example, and it's for those who it is required, it's amazingly good. Significant irregular corneal astigmatism leads to ocular aberrations, which can be negated by reducing the pupillary aperture. In fact, several attempts have been done so far. Pinhole or small aperture optics is something that has been attempted. In fact, there were intraocular pinhole devices which were implanted in a pseudophakic eye in the ciliary sulcus to also achieve this. But in the year 2018, pinhole pupilloplasty surgery was advocated by Dr. Amar Agarwal, and some of the results that he showed were amazingly good. In fact, it left us wondering why this thought never came to our mind. And in explaining that, he also used the Stiles-Crawford effect and said light entering near the center of the pupil produces greater photoreceptor response compared to the light that comes from the edge. And he also went on to explain about the angle kappa or the chord length mu, which is decreased to be around the pupil to be made as small as possible. In fact, we have a new device now done by Epsilon, which is pinhole device, which a patient can hold in front of his affected eye, and he can check which sized pinhole is most effective for him. And this is, we can even try it in front of our eye. Sometimes we may have different size pinhole to give us a maximum effect. Now, the story here is about a patient with such a dismal corneal topography, and that happened only because he came asking for a simple correction of his cylinder 23 years back, and then he had to undergo 7 surgeries, and finally he lands up with a pseudophakic eye with counting fingers 2 meters, and he's an absolute disaster. And that's when this pinhole pupilloplasty comes as a real ray of hope for him. And in this eye, as you would see, this has been described and repeated. So not much of explanation needs to be done. But what you try to achieve is as small a pupil as possible, but your Purkinje image has to fall within. That means you have to literally shape your pupil to be small and in the center. And on the first post-op day, this is a picture. And on the second post-op visit, he improves from finger counting 2 meters to 6 by 36 uncorrected and 6 by 18 with this correction. But this 6 by 18 is an amazingly good vision for him. And we are so much thankful for such a simple technique. That means with this, there's a ray of hope at the end of the tunnel for the patients who are rightly chosen for this particular technique. Thank you so much.
Thank you very much, Suhas, for an excellent presentation. Before we wrap up, there are a couple of questions which have been put up by the audience, and 3 of the questions go to Dr. Priya Narang. Dr. Binakshi says that she device of yours and she found field effects where there were none in Humphrey. The second question is that how do you take care of spectacle corrections that a person has to wear when a person is wearing your device? And the third is that will people agree to any other fields, glaucoma specialists, because normally they believe only in Humphrey and octopus?
Well, I would like to answer each one of the queries that have been raised. Coming up to the point that yes, we all are used to Humphrey and octopus. We have been using it for quite some long time, and these are basically the standard automated perimeters that we have been using. And for any device to enter into the market, it's not going to be so easy. But yes, it might be just a matter of time. Maybe when the surgeons they try to use it, and when you come up with this is how any new technology comes into the market. It does take time to pick up, but then it's always there. So I think it all depends upon the surgeon's use. Coming up to the second question was that I forgot what were the other 2 questions. Like
Spectacle
correction.
How do you?
Yeah, there is it is in the head-mounted device in itself. There is a slider where you can fix up the refractive error of the patient. So there is a provision for providing spectacle correction into the device. So it's very much device. I think you can take a demo of the device and then you can come up to it. Coming up to the interpretation of the visual field, then I think maybe we would like to, probably if they can mail us up with the field that they have got it. Otherwise, we have actually found good equivalence between the Humphrey and this device. So I think that's what I can say here. Yeah.
Thank you very much. Quick question for you, Dr. Meenu. What is the distance from the limbus that you want to put this cannula?
Yeah, it goes translimbally. So from the anterior limbus, 0.5 millimeters.
Okay. Anyone else, any panelist or anybody has any questions? Because we are definitely running over time, though we got the session late. Anybody has any comments on any of the presentations or? Okay, I think thank you very much, all the speakers, the panelists, and thank you, Dr. Kudlu. I think it was a fantastic session. And we will pass on to the next session, which is on challenging cases in cataract. Before that, I think we will have a video for the sponsor. So can we have the video for the sponsor, please?
Yes, sir. Yes, sir. It'll be done.
Thank you, everyone.
Thank you, sir.
Thank you. Thank you.
Thank you so much.
Thank you.
Thank you.
Okay, over to you, Amar, to introduce.
Well, first of all, welcome once again, everyone. And I think Mahipal and Krishna Prasad have done a great session just now. I request all of those who have been there, you can now log out and you can watch it on the IIRSI website, the site, because now we have to move on to the next session. Before I introduce Mahipal back again, I'd like to introduce once again Mohan Rajan, our treasurer. A few comments from you, Mohan.
I think it's been a great session. I think past 2 sessions, the iris repair session, as well as the 2-minute topics has been really very stimulating, very exciting, a lot of take-home messages, a lot of learning, very, very useful tips as well. And all the speakers were really fantastic and all the panel discussions were also very good.
Thank you very much, Mohan. You know, we have 2 great people here in this symposia here, and one person is so dear to me and is looking stunning right now, and that's none other than Elizabeth Yu, who is also one of the key persons in the ASCRS, and the second is Rohit Om Prakash. So I'll ask Mahipal Singh Sachdev, who's the chairman scientific committee and also the president of the AIOS, to now talk and introduce this whole next symposia. Over to you, Mahipal.
Thank you, Amar, and welcome to this next symposium, which is the final symposium of the day in Hall A, and that is on challenging cases in cataract. And we have a lineup of fantastic speakers from across the globe. The moderator, as Amar said, would be Dr. Elizabeth Zhu, and as also Rohit Om Prakash, panelists being none other than Dr. Richard Packard, David Spalton, Gustavo, and Paiwala. I think they are all great people in their own respect and master surgeons. And without much ado, I'll pass it on to the moderators to take this session over and make this conference come to a resounding end with this final session. I'm sure this will be the best of all the sessions so far.
Thank you, Dr. Mahipal, for such a good introduction to this excellent session, which we are going to have on challenging cases in cataract surgery. Well, we have had 3 excellent sessions, and with me is none other than Elizabeth, who is from Virginia Eye Consultants from Virginia State. She is in the Ophthalmologist Global Power List 2015, 17, 19, 20. So that's something which we would be sharing with you with the first talk which she would be having. In the panelists, we have with us Richard Packard, who is as popular in India as he is across the world. He has been doing phacoemulsification since 1979, inserted the world's first folded soft IOL during a rabbit study, implanted the very first Acrisoft IOL. Then we have with us David Spalton, who is the ex-president ESCRS and ESCRS and the program coordinator for ESCRS. Then we have our dear friend Gustavo Victor, who is the General Secretary of Brazilian Society of Cataract and Refractive Surgery. He's the president of Brazilian Society of Administration in Ophthalmology. And last but not the least,
dear friend Matteo Parvella, who has been the president of Italian Ophthalmological Society since 2010, treasurer too in the Italian Federation of Medical Scientific Societies. So these are the panelists. We move on to the first talk, which would be by none other than Elizabeth, who would be talking on dislocated crystalline lens, save the capsular bag. Over to Elizabeth, please.
Well, good morning. And Amar, thank you for allowing us to be here, and Rohit for that wonderful introduction. I know Amar was very complimentary. Rohit, I think you look absolutely stunning yourself today. And so if we would go ahead and get our my video up, that would be fantastic. So, well, let me just go ahead and start talking until we get that video up. When we're looking at the dislocated crystalline lens, you know, there's a few different parts that we have to absolutely consider. One is going to be how dislocated is dislocated, how dense is the lens, the position of the actual lens, if it's more anterior above the iris plane, or is it sitting posteriorly? And of course, is it loose or too loose? And some of that you're going to be able to do with a preoperative evaluation to really assess pupil size, and then lying the patient supine to assess if the lens is something that's going to fall back. Because if there is a little bit of that trap door effect where the lens is going to fall back, it may be that this is best served either with an East Indian surgeon who is going to be a Renaissance surgeon that can do anterior and retina vitreous surgery, or in combination with a retina vitreous partner where they're able to take care of the lens and you can take care of the actual pseudophakic piece. So let's start over here. I'm not sure if I can actually play this. I have no financial disclosures. If you wanted to go straight to slide number 3, that would be great, just so that I could start playing the video.
Advance the slide.
I'm so sorry?
Should advance the slide, I think.
Can I advance the slide?
No, you, the administration people.
Sure.
Admin people.
Yeah. Yep.
Admin, can you just advance the slide, please?
I think
yes, sir. Yes, sir. We'll see.
Yes, please.
If you could just go straight to slide 3, that would be great.
And then advance it.
Is the control with the admin, or Elizabeth you are having?
No, the admin.
No, it's with the admin, sir. Yes, sir. We are checking.
The admin.
Please.
So as we were mentioning, if we've got, you know, so once we do the preoperative examination, and obviously we want to have all the tools that we need to, and this is going to include a combination of various things. This might be that you are using anterior capsular hooks or even iris hooks. It's going to be Gore-Tex suture. It may be where you are utilizing capsular tension segments and capsular tension rings, but it really is going to depend on the actual patient. But for all intent and purposes, if at all possible, if we could go to the next slide, slide 3, it's going to be so important that we try to save the capsular bag, and obviously vitreous tamponade is going to be another key component of that.
Next slide, please. Yeah.
Yep, and if you could play this video, that's perfect. So this is just going to be the first example of just kind of demonstrating. As you can see here, this lens actually was tilted very anteriorly. Sometimes the hardest part of even getting a capsular tension segment into the bag, and you want to do it as early as you need to, but as late as you have to. And obviously a very dislocated lens, you're going to want to do it quite early, especially if you're going to use it to actually stabilize the lens in order to do the nuclear disassembly. There's various different ways that we can stabilize this lens. And for example, where you could use a suture, you could also, through the eyelet, use an iris hook. And the reason I did this in this specific case is because this lens was so tilted anteriorly, enough so that this patient went from a -4 to a -10. Now, sometimes disengaging the actual hook from the actual capsular tension segment can be a little challenging, and so it's sometimes easier just to do within the center of the eye. And then once you have that piece, I like to use 8.0 Gore-Tex, but so important here that whenever you are considering 8.0 Gore-Tex, that it's going to be well buried within the sclerostomy. I do go between 2.75 and 3 millimeters behind the limbus. That really does minimize intravitreal bleeding. And then I go between 2.5 millimeters to 3 millimeters apart. I do like a handshake technique where I actually feed the Gore-Tex suture to itself. It allows for great stabilization, but so important to note that as you are doing this, one, that orientation is correct, and two, that the suture itself is coming through the eyelid anterior to the actual ring piece, because the ring will sit in the bag while the actual eyelet that is used for scleral fixation is anterior and above the bag, sitting pretty much within the sulcus space. And then before we continue the case, providing some level of stabilization for us to do the cortical removal. Now, this is an example of a temporal dislocation of a lens, not quite as much dislocated. And as you can see, this lens is actually still sitting within the sulcus itself. So this is a very good example of where you can pre-place this with the suture already and stabilize it in such a manner to do the case. This is another example, very grossly dislocated. It's going to be much more difficult just to utilize for this broad 6 to 8 clock hour dislocation of the lens. Again, when we are utilizing these kind of anterior capsular hooks, as you can see here, they're broad and rigid as well as long. These are specifically from MST. Very, very nice to place, and you can strategically place them in order to stabilize the lens. But I'll tell you, because they are a little bit thicker, you're going to need a little more visco dissection between the capsulorhexis or capsulotomy and the lens plane itself in order to insert it. And what I wanted to demonstrate here is, unlike iris hooks, which you can kind of pull out of the eye once you're in the clear, these you really need to be very thoughtful and strategic. You are pulling and pushing out of the paracentesis in order to actually remove the capsular hooks from the eye. And then you're going to go ahead and stabilize. This again is demonstrating that I'm going to have a segment here, but a segment is much easier to use than using like a, let's say, for example, the actual eyelet-based Sione capsular tension ring. So I preferentially, while it is more expensive, I will go ahead and use a segment and then further support the segment using some of the ring. As you can see here, just to alleviate any tension, I kind of, I gently push and pull in order to get it into place, because you really want the equator of the bag to be juxtaposed to the sclera. So when you are actually feeding the capsular tension ring, that there is no space or a potential area where the ring can go through the bag, because there is not proper scleral support. And once you have that in position, you don't do the final tie until the lens is actually in the bag and you can make certain that everything is nicely centered. I do 4 throws, and then before I cut it, I bury the knot within the sclerostomy. So these are just different examples of how to actually save the capsular bag. It really is going to be dependent on the lens itself and the different variables that we demonstrated. Thank you very much.
Thank you, Elizabeth. It was an excellent talk, many take-home messages. But what we would be doing is we would be getting on to the discussions after the talks are over, so that we have adequate time for that. So now I move on to the next one, which would be myself, who would be speaking on. So I would be speaking. Can you see the screen?
Yes.
Yes. So I would be discussing intraoperative floppy iris syndrome. So this is a patient who has been on tamsulosin for the last 15 years. He's a blue-eyed 76-year-old patient with a pupil size 4.5 millimeter. Intraoperative floppy iris syndrome is associated with billowing of the iris, progressive pupil reconstriction, and prolapse of the iris to the incisions. There's a reduced maximum pupillary diameter, and the dilator muscle region is atrophic and thinned out, subsequent to which, whenever there is a flow of excess of fluid to the posterior aspect of the iris, there is increased billowing and iris touch, wherein there is an exaggerated response in these patients to iris touch and the pupil constricts. So the strategy is to give a long anterior incision because a shorter tunnel predisposes to iris prolapse. Calibrated side port incision, a long tunnel side port incision is very important in these situations. I use a 500 micron 25 gauge needle which has an outer diameter. The chopper is such that it is calibrated in size and shape. It is 400 and 450 microns in diameter. This gives less fluid access to the side port incision. The chamber is deep. Since the chamber is deep, the stable chamber gives less access of fluid to the posterior aspect of the iris, because if we have a non-calibrated one, the side port incision at times precipitates IFIS. Pharmacomydriasis was not possible much because of atrophy of the muscle because it was in an advanced stage, as you can see in this patient. Had it not dilated, I would have gone in for a pupil expansion device. Viscomydriasis, I used a viscodispersive for this matter, in which the viscodispersive was injected in the sub-incisional part. The classical is the Arshinov's soft shell technique, in which we inject viscodispersive, now viscocohesive, and then the BSS. We have to be mindful of overinflation as it can cause iris prolapse. Sizing of capsulorhexis is very important. We should not have a large capsulorhexis because we do not want any excess of fluid to the mid dilator zone, because that is thinned out and atrophic, and which will cause iris billowing. Once that is done, hydrodissection, we have to be not to be vigorous because that can also cause an iris prolapse. Fluidics have to be on the lower side. As you can see, lower fluidics are being used. Another important strategy is we have to have a continuous irrigation off, because if we have a continuous irrigation on, then we create a situation wherein there is a high AC IOP, and when the probe comes out, there's an iris prolapse. Once that is done, the next part is in the strategy is that the nuclear emulsification. This patient happened to be the one in which it was grade 3 type of nuclear sclerosis. In such a situation, what is required is I go on chopping the nucleus and leaving it there, because I want a stable AC and less excess of fluid to posterior aspect of iris. Nuclear emulsification in this case required higher fluidics, but there's a click in doing this. One, you use a viscodispersive. Second, you make smaller pieces. Then you keep the probe in the proximal half of the pupil. So that will keep you away from emulsifying the iris. Once that is done, then we come to the next step. Use a bimanual if you can, but if you are not used to that, then there is a different way. Retract the sleeve. Once you retract the sleeve, you have a different plane of irrigation and different plane of aspiration. Be smart. Go deep into the bag. Increase the vacuum. See how I'm using the vacuum. I'm increasing it only when I'm holding it. Hold it and then increase the vacuum. You will see the pupil size is the same. So trifles make perfection, and perfection is no trifle. Thank you very much for your kind attention.
That was excellent. Thank you so much, Rohit. We will now move on to the Dr. John Hart, who will be discussing the triad of iris prolapse and cataract surgery. Dr. Hart?
Good morning. I want to thank Rohit and Amar for inviting me. I felt that for the most information in the shortest period of time, I would just create a video. So I've got a video to share with you. And let's see if we can get that going here.
Don't you hate when this happens? Iris prolapse in cataract surgery poses a significant risk to both the appearance and function of the iris. Often, damage to the iris occurs not directly due to iris prolapse, but due to surgical trauma when we push the iris back into the eye. Three sequential elements give rise to the development of iris prolapse. The first element is a floppy iris. This topic was brilliantly reviewed by Dr. Rohit, but in summary, these irides have poor tone, causing them to billow and undergo progressive meiosis during cataract surgery. When IFUS is discovered at the beginning of surgery, iris tone can be improved either pharmacologically, mechanically, or both. Unfortunately, IFUS is frequently not fully appreciated until later in the case. The second element of the triad is wound gape. Wound gape occurs when an instrument that is smaller than the incision is introduced into the eye, or if the wound is not self-sealing. Wound gape is not entirely avoidable during cataract surgery. However, wound gape must be avoided if there is rapid outflow. Rapid outflow is always the final element of the triad of iris prolapse. If the other elements of the triad are present, then rapid outflow must be avoided. Always remember, a floppy iris goes with the flow. During hydrodissection, the wound is gaped by the hydrodissection cannula. Immediately after the fluid wave crosses the lens, rapid outflow is evident as OVD rushes out of the main incision. Failure to recognize early iris prolapse and stop irrigating after propagation of the fluid wave can result in massive iris prolapse, particularly in patients with shallow anterior chambers. Instead, immediately stop irrigation after propagation of the fluid wave and decompress the lens. This creates negative pressure in the anterior chamber, allowing the iris to fall back into place. The tapered tip of the irrigation sleeve gapes the wound whenever it is either introduced or removed from the eye. The irrigation ports are located on the tapered portion of these sleeves. Irrigating while entering or exiting the eye with this instrument creates rapid outflow, often resulting in iris prolapse. Instead, irrigation should be activated only after the tapered portion of the sleeve is completely within the anterior chamber. Irrigation should be avoided when removing the instrument from the eye. The intraocular pressure is significantly elevated during infusion, and fluid can be seen streaming around the irrigation sleeve. Sudden removal of the instrument causes wound gape when the tapered tip enters the wound and rapid outflow as the intraocular pressure is suddenly released. Instead, stop irrigating until fluid leakage around the irrigation sleeve is stopped, usually about 1 to 2 seconds before removing the instrument. There will be no significant outflow and no iris prolapse. Occasionally, despite our best efforts, iris prolapse will occur. Remembering that the iris goes with the flow, we can reposit the iris without touching it by creating negative pressure in the anterior chamber. Aqueous is aspirated, and then the anterior lip of the wound is lifted while irrigating against the iris. The iris will go with the flow into the anterior chamber with no loss of iris pigment. Iris prolapse occurs due to a sequential triad of elements: a floppy iris, wound gape, and rapid outflow. Control any element of the triad fully, and iris prolapse will not occur. But if iris prolapse does occur, avoid pushing the iris back in the eye. Instead, utilize no-touch iris repositing to minimize iris trauma and preserve pupil function.
Thank you so much, Dr. Hart. That was beautifully presented. We will now move on to Dr. Bruna Ventura, who will be speaking on capsular fibrosis and degeneration.
Thank you so much, Dr. Ewan, for the invitation. I have sent in my video, and I think they're going to play it. They had it ready.
Hello, I'm Bruna Ventura, and it's a pleasure to be here today. Besides operating adults with cataracts, I also operate children with pediatric cataracts. I decided to bring today to discussion two scenarios in pediatric cataracts that are very interesting. They are capsular fibrosis and capsular degeneration. In many children with cataracts, we see associated capsular fibrosis. The fibrosis can be present in the anterior, posterior, or in both capsules. When the fibrosis is small and centrally located, we can usually use our routine surgical technique and perform, for example, our capsular rhexis with using our Ultrada forceps. In other cases, as the one in this video, where we have a bigger capsular plaque of fibrosis associated with points of fibrosis throughout the entire anterior capsule, I usually choose to perform the anterior capsulotomy using a radiofrequency cautery called IIRSI that's produced in Brazil. Using this device, I can do the capsulotomy in a very controlled fashion, decreasing the risk of having a radial tear. And after performing the capsulotomy, the size that I want in a circular fashion, I continue with my surgical technique as usual. In this other case, which is very interesting, we have this fibrotic plaque that goes from one side of the equator to the other side of the equator. If I didn't use this device, it would be very hard to perform a circular capsulotomy in this side and even to preserve this anterior capsule. So this device helps me a lot in these very challenging situations with regards to fibrosis in the capsule. Here's the device that I was talking about. It's called IIRSI, and it's a radiofrequency cautery produced in Brazil. The other scenario that I wanted to mention is capsular degeneration. So here's a child that I operated on, and after performing the capsular rhexis using my Ultrada, as I routinely do, you're going to see that when I start aspirating the cataract, we start noticing that besides the opening in the anterior capsule, which I performed manually here, circularly, and here we see it, we also have another opening, which is a little bit smaller than my anterior capsule opening, which is already performed. When I start aspirating the cataract, we can see it easily. This is very interesting, and it can be associated, for example, to posterior lenticonus, posterior polar cataracts. And at this point of the surgery, I use this secondary instrument, so this iris spatula, to make sure I don't have vitreous strands going into my INA tip. Then I inject viscoelastic in the eye to reform the anterior chamber, and after that, I remove my INA tip. I continue aspirating the cortex with a cannula and BSS in a very controlled fashion. In this eye, I made a second paracentesis to continue aspirating the cortex in a very controlled fashion, and this way not cause any vitreous traction. Since this child was younger than 5 years old, I did an anterior vitrectomy to decrease the chances of having a secondary visual axis opacification. And now I'm inserting the IOL that I usually use in children, which is a 3-piece IOL. I always use this second instrument to help to position this second IOL, this second haptic in the bag without stressing the anterior capsular rhexis. Here at the end of the surgery, I close the pupil, reform the anterior chamber with a single air bubble, and I'm injecting preservative-free triamcinolone to help modulate the inflammation in this eye. I also inject subconjunctival dexamethasone for the same reason. Thank you so much for your attention, and it's a true pleasure to be here with you guys today.
Thank you, Bruna. It was an excellent presentation. We now move on to Richard Packard, who would be speaking on fibrosis in the capsule, seen and unseen. Richard, please.
I'd like to thank the Society for asking me to be part of this symposium. I've actually sent in my video, which has a commentary on it as well. So maybe we can begin that. I have no financial interest in the case that I'm showing, but it complements what Bruna has been showing us. But this is fibrosis in the capsule, but in an adult, in 2 places. One where you might see it, and then another where you won't.
Admin,
so
can you
play my video, please?
Yeah.
Yes, sir.
Fibrosis, seen and unseen.
I have no financial interest in this video. Here we will see a white cataract which demonstrated changes that were not expected, fibrosis in the capsule and the cortex. Trypan Blue and Visco have been injected and the capsular rhexis starts normally. A little after the halfway point, something happens. It stops tearing. So what do I do now? I tried a little tear-out recovery, pulling back the way I'd come to redirect the tear. Although it seemed to work initially, it was the wrong decision, as we shall see. It went further out because I was pulling against the capsular fibrosis. So I thought I would try going the other way. Another bad decision, as there was another fibrous band in the capsule which would need cutting. So let's raid the VR instruments, because they have nice, sharp, small scissors. After some snipping, the flap was gone, but it still looked pretty untidy. So let's try and satisfy the inner OCD and tidy up a bit. Well, there is an opening. So, has the tear gone backwards? That's what we need to know. Will I carry on with phaco or convert? Well, the hydrosection was fine, so phaco chop, which is safe even without a capsular rhexis, was the next step. That seemed to go fine, so I thought all would be well. Wrong. The IA presented a whole new set of problems from an unseen fibrotic ring at the edge of the cortex and epinucleus. I decided that viscodissection elevation was needed. This did not initially work due to the toughness of the fibrosis. Eventually, I was able to aspirate the soft lens matter. However, as the last of the cortex was removed, it could be seen that the anterior capsule tear had gone posteriorly. The eye was then filled with viscoelastic to hold back the hyaloid face and position the last piece of nucleus on the iris. The state of the anterior capsule was checked to see whether there was support for a lens in the sulcus, which thankfully there was. The 3-piece IOL was injected into the sulcus and positioned so that the haptics were over intact capsule. The last piece of nucleus exits the eye as the IA irrigation is activated. And the eye is closed.
Thank you, Richard. That was an excellent presentation. How you did it really involved a lot of expertise, cool mind and everything. We now move on.
Some days you just get lucky, right?
We now
Plus
move on.
skill.
Very nice.
We now move on to the next one, which would be by David Spalton. He would be speaking of management of presumed propionobacter postoperative inflammation. David, please.
Okay, Rohit, thank you very much. It's very nice to be part of your symposium and see these really interesting cases. Let me just get up this case that I want to share with you. I hope it's gone blank. Where are we? Just a moment, let me just get this case up. Okay, so this is an interesting patient, and we need to go back a little bit. Just a moment. This patient was a lady, a doctor of pharmacology, had previous laser LASIK in South America, and then had uneventful cataract surgery about 18 months previously. And then since the postoperative steroids were stopped, and I have lost my screen, I can't see it again, so I'm going to go back. I'm sorry, let's go back. Let me just go back this again. I can't get up to full screen for some reason. It doesn't really matter. Okay, so we'll manage like this. So she then had a red inflamed eye, started immediately postoperatively after stopping her steroids. She'd then been treated with intensive steroids, steroid-related intraocular pressure, and had been extensively investigated by multiple surgeons. When I saw her, I think I was the 10th person that she'd seen. Her life was dominated by her eye problems. She was very disillusioned. She was being maintained on antidepressants, Predforte and Combigan for the glaucoma. And if anyone tried to reduce her drops, her symptoms flared up again. When examination, she got early cataract in the left eye, the right eye, 6/15. At that time, the pressure was controlled. And in fact, looking at this eye, you could dilate the pupil up quite nicely to about 6.5 millimeters. She had an M+ lens in the bag, very nicely placed, excellent surgery, and no vitreous infiltrate. Vitreous gel and fundus was quite normal. So the question was, what was the diagnosis and what was the treatment? And I've had a number of these cases over the years, probably 4 or 5, which I think are presumed to be a Propionibacter infection. And the question is, how should you manage them? Do you explant the lens and the bag? You put in a secondary lens implant. And in fact, I've had a lot of success with them, treating them medically to start with a course of high-dose ciprofloxacin orally for 3 weeks. And in this lady, her symptoms improved over about a month. We were able to stop the steroids and her glaucoma treatment, and she's been completely asymptomatic for over 3 years now. So Propionibacter, it's a gram-positive anaerobic rod. It's rather difficult to culture from the vitreous because you need prolonged anaerobic culture for 2 weeks, and therefore vitreous cultures taken as surgery are often negative. PCR is said to be more accurate. It's been a recognized but unusual course of chronic uveitis. Often you see these fluffy intracapsular plaques, but in this lady, there was nothing there. And histologically, the bacteria is often associated with residual soft lens matter. A lot of the cases have poor response to intravitreal antibiotics, I think because the intravitreal antibiotic lasts for a relatively short time and doesn't really penetrate sufficiently to get into the capsule bag. And a lot of these patients have their lens explanted with the bag and then go on to have a secondary procedure, which is obviously a fairly major undertaking and not what the patient wants. But I think the point is that these eyes have a chronically inflamed blood aqueous barrier. It's broken down. Penetration of oral antibiotics is possible, and it's well worth trying medical treatment prior to major surgery for them. So one doesn't have to rush in to surgery straight away. And as I say, I think I've probably had 4 or 5 of these cases over the years that have responded to high-dose ciprofloxacin for about 3 weeks. So thank you very much. There we are. Let's close that.
The PCR confirmed the P. acne, sir?
We didn't do with PCR. It was a presumed diagnosis on this case. I mean, one of the problems is, sorry, I'm just going to get my escape screen again. Stop share. Yeah, I think the problem with these cases is how much you investigate them prior to surgery. And it's obviously quite nice to do a vitreous tap. The vitreous cultures are often not successful. The PCR, if you have it available, is probably the best way to actually go. But we didn't do that. This was a presumed Propionibacter infection.
Thank you.
Very nice.
It was a brilliant talk, David. Now we move on to Samuel Mascott. So he really doesn't need any introduction, but I would be falling short if I do not really introduce him. He has more than 100 scientific articles and 2 textbooks. He is one of the 50 most influential ophthalmologists. He has been the past president of American Society of Cataract and Refractive Surgery, and he is in the board of trustees of the American Academy of Ophthalmology, and he has US patents in intraocular lens designs. Samuel, it's a privilege to have you here, and he would be talking on management of traumatic cyclodialysis in cataract surgery. Over to Sam, please.
Thank you, and good day to everybody. I mean, I have to say good day because it's really early here and it's really late there. I really enjoy being part of this. I mean, never too old to stop learning. I did send in a narrated presentation, so if you have that, please play it. If not, I'll share my screen, but you should have that.
Yeah.
Admin is doing it, Rohit?
Yes, sir. Yes, sir.
Yes. Good evening, sir.
Is admin okay, or do they want me to share my screen?
Admin.
Is it okay?
Yes, sir. Yes, sir. We are just working on it. Yes.
Yeah.
Please share the screen.
No, I'll give them another moment or so.
Yeah. Admin, should we ask Dr. Samuel to do it?
I think so, Rohit.
Yeah. Sam, could you do it at your own time?
No, sir. We are doing it. We are doing it.
Yeah.
Here we go.
Yeah.
So play it.
Please do the slideshow.
Slide. No. Yeah.
Up top. There you go. Good evening, colleagues. I'm going to talk about cataract surgery in the presence of a cyclodialysis cleft and whether you want to use or lose that cleft. I have no relevant financial disclosures. What are the issues with regard to a cleft? Well, certainly if there is hypotenuse maculopathy, then we want to close that cleft permanently. However, if the cleft is maintaining intraocular pressure control for us, then we might want to retain it. However, an open cleft at surgery is a risk for a large intraoperative suprachoroidal effusion and potentially hemorrhage. So irrespective of whether we want to use it or lose it, it has to be closed prior to cataract surgery. We can use this case as an example. This is a 57-year-old woman, a year and a half past a bungee cord injury to her left eye. She has marked zonulopathy, anterior vitreous prolapse, modest pupilloplegia, and her angle was closed for 360 degrees with the exception of a 1 to 2 o'clock hour area in the infranasal quadrant that has kept intraocular pressure at normal since the injury without medication. So the plan was to retain her cleft or use it for long-term purposes. Looking here at a UBM, we can see on the left side the angle is essentially closed and the iris is close to the cornea. However, in the area of the cyclodialysis cleft, there is a obvious deepening of the chamber and a potential space for fluid to be misdirected during surgery into the supraciliary and then suprachoroidal space. At surgery, a marker for the anterior capsular rhexis is placed on the cornea, and non-preserved triamcinolone is injected into the chamber, followed by an anterior vitrectomy in a bimanual fashion. Once the prolapsed vitreous has been removed, a dense OVD is placed over the defect and in the chamber. And then working through an opposing paracentesis in an ab interno fashion, a PC7 needle is passed across the chamber, underneath the iris, through the ciliary body, and out the sclera. The second arm of the suture is also passed through the paracentesis, about 3 millimeters apart from the first pass, and this suture then creates a temporary internal cyclopexy. Cataract surgery is then carried out with capsule support hooks, placing OVD when we come out of the eye, and using a bimanual approach to remove the residual cortex. A rigid CTR is injected into the capsule bag, after which an Ahmed segment is fashioned to the sclera infratemporally. It's essential to clean the LECs very carefully to prevent capsule contraction postoperatively in any zonulopathy. Here the OVD is removed with the vitrector, but it's noted that there is still vitreous prolapse through the incision, and so a pars plana approach is the best method. Once all the fluidics have been completed, the temporary cyclopexy suture is removed, and the incisions then tested with fluorescent dye at physiologic pressure, surgery then completed. The outcome was very favorable. Now 7 years following surgery, visual acuity is still 20/20. Pilocarpine is used once daily to keep the cleft open, and pressure has been normal since surgery, between 7.5 and 16 millimeters of mercury. Thank you for your attention.
Brilliant talk, Sam.
Fantastic.
Fantastic. I think you have opened up another aspect of looking at things, how we can use UBM to our advantage, and doing things and ending up with results which would be beneficial to the patient. Now we move on to the next one, which would be by Mary Jose, who is basically a very close friend of ours and who has been dealing with bag in the lens one. So she would be talking on Yamane meets bag in the lens. Over to Mary, please.
Thank you very much, Rohit, and thank you for the invitation. Thank you also, Amar, for this invitation. It was really very nice to see you again. I'm not sure I have uploaded my presentation, and I would like to ask the administrators to also start the slideshow. Yeah.
That's right.
Okay.
Slideshow.
Yeah, okay, thank you very much. I will do the narration because this is only the video that you will see. The next, please. I have to disclose that I have, of course, the intellectual property on the back in the lens, the ring caliper that is licensed to Morcher. Also, you will see that I will use bean-shaped rings, and these are also licensed to Morcher, and I will also use a capsule tension ring from Morcher, but I will not have no financial interest in that. Next, please. Now, you know that I'm very much interested in the back in the lens, and the question is that I will present to you a case of a dislocated lens in children. The question is, can we also use the back in the lens in these cases? Well, I will show you that it is possible. For next, please. With the back in the lens, we use the advantage that there is a space behind the lens that is called the Berger space, defined by the posterior capsule and also defined by the anterior highway. And you have in the periphery the ligament of Rieger that attaches the anterior highway to the posterior capsule. Is that also the case in kids? That's the question. Well, now I'm doing a study to evaluate the variations of that interface. Next, please. And indeed, we do know that in babies and in children, they do have, in some cases, they do have a quite large Berger space, but in some children, there is a dysgenesis there. And they have, for example, typically a plaque at the level of the posterior capsule. The anterior interface is not normal in those children. Next, please. So the case that I will show you, and maybe activate the video, is a child, 4 months old child, that presents an, not yet. It's a 4-month-old child that presented dislocated lens. I want to preserve the capsular bag because I think it is very important in those children to have, yeah, okay, thank you. And I think it is very important in those children to try to get and to keep an interface between anterior chamber and posterior chamber. I define 5 dots, and these are all very important. The peripheral ones are the ones that correspond to the peripheral side of this dislocated lens, and there I will position my iris retractors. I have chosen that very purposely because these are the external parts here where you will have the highest force, you have the best suspension of the lens complex at that place. Retraction of the lens is at the opposite level, and there you know that we have there very retracted and most probably also collapsed vitreous or whatever. You have to pay attention in those children because you will snap very easily, like in this case, the posterior capsule, because the posterior capsule and the anterior hilate are not normally related to each other. So there is not so much legal ligament like it is in normal case. Now I inserted here a capsular bag and you see how loose the zonules are. You could eventually also inject here, but don't do that. And I tried that. And then you find out that there is a remaining ligament of Rieger somewhere in this place at that level. So I insert the ring caliper, perform my anterior capsulorhexis of the right size, take the ring out, and then I can perform my posterior capsulorhexis, injecting first the viscoelastic material in order to separate beautifully the posterior capsule from the anterior hilate. I can then perform my posterior capsulorhexis of the right size, the same size than the one of the anterior capsulorhexis. We keep the capsules for eventually further examination in the biobank. Now I insert the bag in lens by manual insertion. I glide the both anterior posterior capsules within the lens groove. Now here are the bean-shaped rings. I try first to recenter that complex capsular bag, ring caliper, and back in the lens to center that as much as possible. I was suspicious that I was able to use the beans only in order to center it because luxation was really important. And you saw as well as I saw that the zonules are really, really very, very weak. After having inserted the bean-shaped rings, centration is better, not optimal. So I took a Prolene 60 and I used now the 2 last marks that haven't been used up till now. And I insert both ends of a piece of thread of Prolene 60. I will lasso it within the groove of the lens here. I will lasso it here so that I have 180 degree of support of this capsule. And I pull here at those 2 ends. And then thanks to Yamani, I just have to trim the right size by cutting the thread at the right size and then burn it in order to have the good fixation at the level of the sclera. Very elegant. Now, these 2 points are absolutely important. This was the middle, the meridian of the traction forces of the lens complex. So I have put those two marks here in order to have the maximal centration of this lens complex and back in the lens complex. We have done that now for a couple of times in children. The first day postoperatively, they can use their eyes very easily, quiet eyes, absolutely no inflammation at all, no vitrectomy at all was performed, no need for a vitrectomy. And I must say that we have now sufficient cases in order to make a publication out of it. Thank you very much for your attention.
Fantastic, madam.
That was absolutely beautiful. I can't wait for the panel discussion to ask you about that bean-shaped, the retention ring. That's phenomenal. I have the pleasure of introducing Dr. Lisa Arbiter, who is definitely a mentor and hero of mine. She's an adjunct professor at the Moran Eye Institute, as well as a former president of the American College of Surgeons. She needs no introduction. She's best known for teaching complex cataract surgery, advancements in cataract surgery, and we are very fortunate to have her to give us a lecture on avoiding intraoperative vitreous traction.
Thank you so much for the beautiful introduction, and it's really an honor to be here with so many of my dear friends, mentors, and mentees and colleagues. And I agree with Sam. There's no better time to learn than now. You have all the more time for it, and teaching is all the better. So I have uploaded the presentation as asked. Hopefully admin can do that for me. Otherwise, I have it ready to share.
Admin? Yeah.
Very good. And Amar,
thank you for the opportunity to present avoidance of vitreous traction. We must limit the sphere of influence of our vitrector, which means using the smallest gauge available to us, the lowest effective vacuum, the highest cut rate we can obtain. We, of course, need tight incisions and a normotensive globe, and we want to exit on foot position 0 so we don't encourage vitreous to follow our vitrector as it exits the pars plana incision. I think I'm going to be grabbing cortex, but as it turns out, I'm grabbing vitreous around loose zonules. You see how stretchy and elastic it is, and we can't reflex it no matter how we try. Rather than pull like this with traction, I should have taken a scissor and cut it free. Don't whack or sweep. I'll show you why not to sweep. And if you whack, always have scissors handy and don't lift it, and you can particulate identify instead. As we remove the cannula from the paracentesis, you can see the vitreous follow the gradient of low pressure. When we cut it at the incision site, there's no real traction. However, you can very visibly see why we don't recommend sweeping the incision any longer, because you can see the tremendous tractional forces that are occurring through the pupil with this maneuver. That I'm putting the vitrector through the rent in the posterior capsule, you can see that as much vitreous is coming forward from the vitreous body as what I am removing anteriorly. And as we withdraw, there's often a wisp to the incision, as you might see at the slit lamp the next day. Now we're going to intentionally break the capsule and plan a posterior incision through the pars plana. And canalog or triescence is particulate identifying, and the moment we pull out with our other instrument, you can see that vitreous followed, and now we're going to go through the pars plana, still with irrigation anteriorly, but pars plana below. We've amputated our anterior posterior attachments. On the one side, it actually removed the vitreous from the incision. On the other, you can see there's no traction when we go to sweep it from the wound because there's no further attachment. Direct entry, measure 3.5 millimeters back to find the pars plana. Perpendicular to the sclera, make sure you see the point of the MBR blade in the pupil to be sure you're through and through. This is an old 20 gauge, so it's slightly larger for the flat edge. And then always watch the port while accomplishing this. We must have a plug or a temporary tie suture, and always suture this. We have to be sure there's no incarceration of vitreous. Next, we're going to see that we're going to do a trocar system insertion, and we're going to pull the conj so it's not coincident. We're going to go 3.5 millimeters back, limbus parallel to make a scleral tunnel. The appropriate angle is 30 degrees to the sclera, and then enter completely. And you'll see that here it's a little extreme, that the collar pops backwards, so that we're sure we have not broken the ceiling or the floor of the scleral tunnel, so that when we come out we can apply direct pressure. And I'm told that it's preferable, rather than the pressure that I've applied here, to actually crush it with the tip of the trocar in order to be sure that there is no incarceration of vitreous. This should seal nicely without any bleb.
Here we're going to see that we can only apply the trocar when we know that we have a firm eye, because you can see the kind of pressure it takes. And I'm showing this Miyake modified view that Liliana Werner helped me with in order to demonstrate the pressure and also to show in your mind's eye what's happening inside in the pars plana. You can see how it tilted backwards because we had a really good scleral tunnel, and then when we bring the vitrector through the cannula, it comes through again. Now this is a regular 3-port vitrectomy, and it's just an endoscopic view of this 23-gauge incision that was made directly, and you'll be able to see that the reason that it's absolutely critical we have a scleral tunnel incision if we're not going to suture, if we want to be transconjunctival, is that here in this complete vitrectomy you can see the kind of gaping hole that is there, and we would be filling that with vitreous rather than having
Patney.
Thank you for your attention.
There's so much more to discuss. It's a 2-hour course. I'd love to be more thorough, but thank you for the opportunity to introduce some of these concepts.
Brilliant. Very nice.
Thank you, Lisa. That was a brilliant talk. Luckily for us, we are the last session, so we can extend the panel discussion to our convenience. So we would start with the panelist, Gustavo Victor, about the first talk of Elizabeth. Would you do anything different in the 3 cases which she showed, and what is your approach to such situations?
Good morning, everyone. So you talk about what specifically talk?
Yeah, Elizabeth's talk, yeah.
So the last one?
The first one, yeah, in which she put a CTS head on in the first, and she used iris hooks to support. Would you do something different, or would you go on with it?
Yes, so usually we do the 3 plans incision and corneal clear incision. So for the iris prolapse. So I think can avoid the most of the iris prolapse if you use the 3 plans corneal incision. I think it's one thing that I can talk about this. Are you talking about this first talk?
Yeah.
So I had talked about managing a dislocated crystalline lens and the different techniques on how to save the bag. If you had any comments about that, that would be great, on any nuances that you would do to manage a dislocated lens.
So I usually I think you can combine the Yamane technique with this one. I think it's my best option, and only we can remember that most of the dislocation lens usually we need to stay with our mind that the pseudo-exfoliation of the lens, it's a very important thing that we can think that can exist without the many clinical signals. So it's subclinical pseudo-exfoliation and can do a lot of dislocation lens, and we only think about this.
Elizabeth, if I may ask you, you used iris hooks in the first case to start with.
I did. I used, so it was a dislocated lens that was dislocated anteriorly. So I used an iris hook to actually engage the eyelet of the capsular tension segment to keep it stabilized.
What is your indication for using iris hooks, and in which situations you use capsular hooks? Are there specific indications, or was it the availability which made you go in for that?
So it depends on how far it is also away from the actual scleral wall. If it's going to be extremely dislocated, using even a capsular tension segment, it'll rock on you. So that's not going to be enough, where you would use a broad segmented approach with using the capsular actual anterior capsule hooks. And then obviously, if it's not tilted and dislocated, you could actually go ahead and engage the actual segment into the sclera and pre-place it before you actually start the case. But it really does depend on how far and how much dislocation has actually occurred.
Sam, you are known for looking into these, dislocated bags. Your input into this, into her talks, into her 3 case scenarios.
Yes, just in general, I really prefer the capsule support hooks to IIRS hooks for several reasons. Number one of the problems of having diffuse zonulopathy is a very floppy posterior capsule, and the capsule can easily get engaged into your phaco tip, your IA tip. And so one of the things that the capsule support hooks do is they reach out to the equator of the bag and they keep the posterior capsule on stretch. So as Elizabeth mentioned, we like to place CTRs as late as we need to, but a CTR will also keep the posterior capsule on stretch. So you have to decide, one of the things that you want to accomplish when you're doing a case of that nature is preventing floppiness of the capsule. So because the capsule support hooks go out, that's one reason. The other thing is that the IIRS hooks are not manufactured to really be capsule friendly. Sometimes there are barbs at the very end, and you go through this exquisite surgery trying to maintain the bag, and you put devices in, but you have these IIRS hooks pulling on it, and it can cause a tear in the anterior rhexis. And once that happens, everything changes. You can no longer use the anterior capsule to support. So I have a very, very strong preference, and I don't recommend the use of IIRS hooks to hold the capsule bag.
Absolutely.
Moving on to the next talk, Richard, your fat boy chopper, you were the first one to use as calibrated side port incision. So, so your take on using calibrated side port incision in these situations?
Right. The reason I did this is because I routinely would use a bimanual irrigation aspiration, and I wanted my chopper to be the same size as my irrigation aspiration. And so I would just then make an incision of the same size. And therefore, by using the calibrated chopper, as you say, that you don't get significant leakage. I mean, it's very interesting when you watch a lot of live surgery is to see how much irrigation fluid is actually coming out of the side port. And then people start complaining about the chamber being unstable. And the main reason the chamber is unstable is nothing to do with the machine at all, but it's purely and simply because there's been too much irrigation coming out. And when you have an eye like you had with the with IIRSI, this is just going to cause all kinds of problems. So I agree with you. I think there is a distinct advantage in knowing this and having an appropriate sized instrument through your side port.
May I just say that McCool once measured 22 cc's a minute coming out of a standard paracentesis with a standard chopper in there.
Yeah, absolutely.
The other thing, Richard, is that there's an enormous advantage in using a bimanual IA, because if you've got your IA under the IIRS, it's going to bring it forwards and wash it out. Whereas if it's above the IIRS, you are in a much better controlled situation.
Now, Ray, can I ask you, in the talk that you showed us, you didn't use anything to hold the IIRS. Do you ever use IIRS hooks or a Malugin ring in these IIRS cases?
Yeah. My indication for using Malugin ring or IIRS hooks is when there is associated pseudoexfoliation, or when I feel that there is any zonulopathy, or when the pupil size is less than maybe 4.5 or 4.6. So adrenaline, epinephrine is also a very good adjunct in these things, because that also helps to dilate the pupil. But it has been seen that as and how the time passes, there is a degeneration of the dilator muscle, disuse, atrophy of the dilator muscle. So once you discontinue for a long time, it may take a much longer time for the for the tone to come back. But if the patient has been using, we did a study and we found in those patients where the where the tamsulosin had been used for more than maybe 5, 6, 7, 8 years, the effect of epinephrine is reduced because there is atrophy of that. The tone is also doesn't come out because there's hyalinization and degeneration of the muscle. So that is one factor which is definitely there.
Can I add one point, Rohit?
Yeah.
Rohit, I just want to know, because in IIFSC, if you have a pupil which is less than 6 millimeter, my cutoff is 6 millimeter. If it's less than 6 millimeter, right in the beginning of the surgery, I use a pupil expansion device, either an iris hook or a Mulligan ring or a BX ring in the beginning itself. Halfway through the surgery, I don't want to get into a problem. It's going to make life and a little more difficult, and also it will be very messy at that point of time.
Yeah, but we have to realize that, what is the basic pathophysiology of things getting exaggerated into a full-blown IFIS. We have to realize that, the dilator muscle is atrophic. So that is thinned out. And that is, whenever there's an excess of fluid, where not to the anterior part, but to the posterior aspect of the iris, that is the most vulnerable part. So whenever there is any fluid access to the posterior aspect of iris, there is billowing. So what we are doing is we are creating a situation where the chamber is deep. Well, I tell you, you start using calibrated side port incision, as Richard would also agree with me. With a stable chamber, you are not allowing fluid to go to the posterior aspect. With adrenaline as an adjunct, with all the strategies in mind, your use of Mulligan ring would definitely come down. 6 millimeter, you will come down to 5.5, 5, or maybe 4.6 for that matter.
Yeah, Rory. Can I make some comments on that?
Yes.
I think because the pathology is indeed atrophy of the dilator, you need the strongest pupilloplegic medication you can preoperatively.
Yeah.
And that's why epinephrine doesn't always work, because you're stimulating a dead horse. But I've used atropine over the years with great success. The problem is you have to start it preoperatively, and you have to be careful in men who have stopped their tamsulosin. If they're still on it, it's a lot safer. You don't want to send people into acute urinary retention during cataract surgery. That's not a good thing. But if they've had prostate surgery, or if they're still using their alpha agents, then it's safe to do that. The other thing is, I agree completely with Mohan, and that is the intraoperative pupil size at the outset of surgery, after you've done everything. You've dilated them, you've stimulated with epinephrine or phenylephrine. That pupil size will then determine what's going to happen next. If that pupil is above 6.5 or so, 7 millimeters, you won't have any problems. It's extremely unlikely, because the fluid is not going to get behind the iris.
Yeah.
That's the key issue, as you mentioned, Rohit.
Yeah.
So, but if that pupil is smaller than that, and you then tend to have some post-iridic flow, that's when you get into trouble.
Yeah.
So I always used intraoperative dilated pupil size as a guide whether or not to put in a Mulligan or similar device.
Absolutely.
And just one point there, between the pupil expansion devices, it's using a ring is going to be much preferred than using iris hooks for various reasons. When you're grabbing atrophic tissue, it'll just rip right on through, and the iris hooks create a greater dilated pupil postoperatively than using a ring device. And lastly, the iris hooks will tent everything up more anteriorly, which will drive greater fluid behind the iris itself. Now, intraoperatively also, I do not believe in continuous irrigation when you're coming out of the actual wound for the reasons we discussed. But during surgery, using a low flow continuous irrigation will actually keep everything stable, so you're not causing billowing of and bouncing of the pupil, which will make it come down more. So continuous irrigation at low flow intraoperatively, and then making sure to turn it off before you go in and out of the wound, is actually extremely helpful to manage the actual pupil, to keep it from mechanically bouncing around.
Yeah. One other thing, if I might just add briefly, you could consider Healin 5 in this situation
as an Arshenov soft shell. Basically, I think it's one of the few places that Helin 5 is useful, and you can put it down on the peripheral cornea and then iris, excuse me, on the peripheral iris, and then pack it in with whatever it is you want to work through. Usually a dispersive will work well, but almost anything, as long as you've got that set, and it will keep the iris kind of plastered down for a good part of your irrigating process.
Yeah,
I think dispersive
but you can, well, the problem is for every patient. First of all, this IIRSI syndrome is very, a lot of patient now, elderly patient has something like this or something similar, like iris atrophy or iris that respond in a different, unusual way. So the key point is always how we detect the incision sites. We need to avoid that when the liquid, the infusion go behind the iris find the way to be engaged. And this is also a balance of a height of your bottle, because also all the novelties in phaco, the height of the bottle is always mandatory to maintain stable your anterior chamber. And then also when you inflate a disco, because disco needed to be enough, but not to remove the iris inside. I normally use the disco to enlarge a little bit and to maintain the anterior chamber stable from these cases. Secondly, capsular IIRSI should be very well performed by new device like Zetto that have a round centered rexis in the middle. And I split the nucleus because normally these patients are very hard nucleus with a mylope, because I want one more time avoid difficult maneuver, because one more time when we face an iris like that, it's difficult to manage and sometimes you lose the control. So you need to remember the first point. If you start with a wrong incision too short, it's quite important to stop and make another incision by side, because if not, you don't get the final of the surgery. And that is what's normally happen, because the complication rate in this patient is over 30%, 30% over.
Thank you, Matthew. Now, Richard, there's a saying that, you know, if you are not good to the tissues don't respect you. So I'm talking in reference to the triad of iris prolapse and cataract surgery. When you teach, how often do you say that you should always measure the size of the pupil before the surgery and after the surgery to see whether there is any trauma and what has caused the iris to, you know, constrict? So is it, yeah, please.
Okay. I think John actually gave us a very simple and straightforward way of looking at iris prolapse. And again, as much as it happens with IFIS, it's to do with the fluid dynamics of what's actually happening inside the anterior chamber. And by far the commonest reason for iris prolapse is an inappropriately sized phaco wound. Yes, obviously you're more likely to get it with an IFIS patient because the iris is that much floppy. But you know, you would see this with residents where they would go in aggressively doing a hydrodissection, and then they wonder why, when the fluid goes underneath the iris, it comes out of the wound. I think one of the other important things that John showed us is what most people try to do is to push the iris back with a bit of viscoelastic. This is exactly the opposite of what you should be doing. When you get the iris coming out, decompress the eye. Once you decompress the eye, it flops back in without any problem. And be also prepared to put a stitch in if your wound is too big, or make another wound. You know, it's one of those things that annoys all of us when it happens, but it is perfectly possible to deal with this problem so that it isn't going to ruin the pupil size, or you're not going to get pigment dispersion, as you can do if you don't deal with the iris prolapse properly.
Yeah,
David, anything you would like to add?
Yeah, I mean, I think one of the things with the iris, if you get an iris prolapse, is to get it back in the eye immediately, really. You don't want to, the longer you leave it out, the more pigment dispersion and the more ischemia that you get, and the bigger and the more likely chance of a distorted pupil. And these patients, when they lose the iris pigment epithelium, often get a lot of glare post-operatively because there's some translucency there. I think going back to what you were talking about earlier on with the IFIS patients, I like to have if I have any doubt about the size of the pupil, I actually use a ring. I think there's no downside to using rings at all in these patients. And so I think, Rohit, your case was quite a challenge with that small pupil. So I tend to use rings early on.
Rohit, may I make a comment?
Yeah, please.
So several things come up. The issue with iris prolapse after hydrodissection really involves, it's not just fluid going behind the iris, it's fluid going behind the lens. When the fluid is pocketed behind the lens, and basically you're decreasing the volume very suddenly in the anterior chamber. It's not that it's behind the iris, it's behind the lens. The lens prolapses forward, and when the lens prolapses forward, you see a sudden outrushing of OVD. This is a sudden outflow, and that is the third step in the sequence of iris prolapse. Now, I can tell you, I don't believe constructing the wound in a different way is helpful in these patients. And I don't believe that measuring the pupil is going to help you in all cases, because especially in novice surgeons who are working on hard cataracts, these cases last longer. When the case goes longer, they remove their viscoelastic, which is holding the iris back. Once the OVD is gone, the iris starts to billow. Billowing is actually the trauma that causes it to become miotic. It's not really necessarily iris touch, it's billowing. Think about it, because billowing is traumatizing the iris all the time. Touch is happening, but it's not happening nearly as much as when the iris is billowing. And so these cases, the most dramatic cases are always in cases that go a long time and in harder cataracts, because the OVD, which is optically invisible, is gone and it's not holding the iris back anymore. But the last step is the critical part, and that is monitoring flow. Monitoring flow is the key. If you don't irrigate and you allow the pressure inside the eye to normalize to 0 before you come out, the iris won't go out. The iris goes with the flow, period. Okay? It's not magic. So if you have a normal size, normal length incision, it won't come out. I didn't use iris retractors or Malyugin rings in any of the cases you saw on my video. Okay? I don't use them. I've used them exactly 2 times in over 15 years. I don't need them. And most of you who are experienced surgeons won't need them either. Epinephrine works.
Can I make a point? One of the things, particularly, I mean, what you were talking about is this loculation of your hydrodissection fluid in the capsular bag, pushing the intraocular pressure in the posterior chamber and then causing prolapse. You don't have to do the hydrodissection immediately after your rhexis. One thing you can do is to do your capsulorhexis, do a fracture of the nucleus and crack it. And so you've got the nucleus in 2 parts, and then you can hydrodissect it quite safely because there's no loculation of fluid in the eye. The fluid, as you hydrodissect, the fluid will come out of each half, and that works quite well, particularly in eyes with very shallow anterior chambers.
You're right, David. The thing is that because of our capsulorhexis being relatively small, 4 to 5 millimeters, once the fluid wave passes across the lens, you need to stop irrigating. That's the key, because especially newer residents, they continue to irrigate, And if they just stop right when the fluid wave goes across, this would not create a problem. And decompressing that lens creates negative pressure, and that draws the iris back into place, period.
I would just like to emphasize your beautiful demonstration of that, where I think people think of hydrodissection as just irrigating, but I think of hydrodissection as a slight ballotting motion while you irrigate, so that you're decompressing the lens as well as the posterior lip in a very subtle fashion, so that when you do that, you never will get tear out of the posterior capsule, and you also won't get iris prolapse. The other thing you showed very subtly was if you can see the iris coming up to the internal lip of your wound, to the decimated lip, the time to stop. That's the exact moment where you then need to decompress the chamber through the paracentesis.
Elizabeth,
John, but it's the fluids that is the key point, as you said. But listen, when it's happened to every surgeon. When you perform a too short incision that do not over the iris, you start getting the trouble. Yes, are the fluids that improve this trouble, but because you have nothing to counterbalance the round of the fluids inside, and the iris look for the street for the incision.
I would add one thing to your comment, just briefly. If you look at the internal lip of your corneal incision, if the iris extends beyond that, the iris is at risk for prolapse.
Yeah.
Period. Okay. And that's at any point in the surgery. Okay. So what that means is you have to be careful of your flow. If you take care of the flow, the iris won't come out. Period. End of statement.
Absolutely.
It's okay.
Right.
Very good.
Well, great discussion. Let us, in the interest of time, we will go on to a few more questions that were definitely asked by the audience. Dr. Ventura, with regards to your radio frequency capsulotomy, let's discuss a little bit about the fibrotic capsule itself. Now, is this available commercially? Or can it be used in those high pressure white cataracts?
Liz,
it is available commercially. The one in, I only have used this one that's a Brazilian produced device, so I really can't comment on the use of other radiofrequency devices. In Brazil, it is produced commercially, but since it is an inexpensive device, you have to order it and then they make it for you. You can't just go and buy, let's say, 10 out of it. It's very inexpensive. So none of the big companies sell it because it's inexpensive. With regards to the white cataracts, in adults, it kind of fragilizes the capsulotomy. So that I don't use it in white cataracts. In white cataracts, I prefer other techniques.
Can I make a comment on Ventura's presentation? For the plaque in children, you use immediately your device in order to cut the anterior capsular rhexis. I think it is important to know that these plaques in children, you dissect them and you can take them away from the anterior capsule. They are not very attached to the anterior capsule, and you really can detach them in their totality, which makes it which gives you a freedom more of ease to continue your cataract surgery. So I am more in favor of anterior capsular rhexis, dissect it from the anterior capsule, the plaque, and then take the plaque out, and then you can continue your surgery. That's
a very interesting comment, because I showed 3 cases. The second one, that was a fibrosis that goes from one side of the equator to the other, you can clearly see that, like, that's the capsule. You couldn't detach that fibrosis. I agree that in some cases
you can. But it is bimanual that you have to detach it, and it's really peeling. It's really peeling away, and then but you are absolutely right. Your anterior capsule, even in those children, will not have that flexibility that you expect in children children, because indeed that capsule has been, it's a disease capsule. There is a dysgenesis in that capsule, and there is probably that this is a dysgenesis due to the tunica vasculosa and the anterior capsule.
If I can
one thing that I always
radio frequency, I have adopted this more than 25 years ago with a device similar to what I see, and the technology is very good. But now, in my experience, the technology that we have today, like Zepto, has a main difference. First of all, in 1 microsecond, the cut is done. And that is absolutely better when we face white cataract, like Richard has shown before, because you know that with femto or with this device that take time to make around, all the leakage, white leakage, don't give you the opportunity to see better, and the laser doesn't work. So it is a very effective technology,
yes,
but
sure.
I think that if I can deploy it now, I use something faster. And that
it's interesting.
Capsular coarctation, because with radio frequency you have a thick border because you're cooking the anterior capsule.
With Zepto,
Richard?
it is going to be very interesting when we have it in a size for pediatric eyes. I just wanted to mention one thing that's very important if people are considering using the radiofrequency cautery in these eyes with fibrosis and in children, is the fact that Mary mentioned. It makes the capsule a little bit weaker than if you had, let's say, done a capsulorhexis. So my routine in children, in my routine surgery, is to insert endocapsular tension ring in all children with the 3P file that I showed. When I use the radiofrequency cautery, I don't insert an endocapsular tension ring in this scenario because of the fragility. So I take that into consideration in my technique.
Okay.
Dr. Packard, any comments
Plasma
there?
knife. Plasma knife. Anybody's got plasma knife? Anybody has got experience in plasma knife? Daljit Singh's group in Amritsar, plasma knife. Rohit, you can talk about that.
No, I don't have any experience. I have not used it.
Yeah, but Daljit Singh's group, they use a lot of plasma knife, similar to the radio frequency.
The right. The Oertli company made a radio frequency device 30 years ago, and when the femto laser appeared, they reintroduced it, and is actually available to be attached to their phaco machine. It is commercially available in Europe.
Yeah.
Oh, don't
But
forget.
as Bruna said, the problem is that it doesn't give you a strong capsulotomy. It's what we used before we had Trypan Blue.
Don't forget that all those techniques
Richard, when
lens
first came in.
It's available before.
It's still available now.
Yes, sir.
Yeah.
It is available.
Great. And Dr. Tassignon, what were you mentioning? And then Dr. Spalton.
Well, I think that all those techniques that heat above approximately 60 degrees of Celsius, they will kill the cells. The lens epithelial cells, you kill them starting from 55 Celsius temperature of 55 degrees of Celsius. So that means that the anterior capsule may become weaker with time. This is, you have to pay attention for that.
Great. Dr. Spalton, any last comments there?
No, well, the only thing I was going to say was ask Richard whether the capsulase works on these capsules.
Yes, it does actually, surprisingly.
Yeah.
Jorge Alio has shown a wonderful case with the sort of fibrosis that I showed in my case, where the capsulase are actually cut straight through it. I was surprised that it did, but it does. In the same way that, as Matteo was saying, Zepto does it because of the way the technology actually works.
Great. Now, there was a question for Dr. Maskett. In the presence of the psychodialysis cleft, why would you keep it open? And how does pilocarpine help? Oh, Sam, I think I caught you while you were walking. I'm sorry.
Oh, it's okay. I had to come plug in. I was running. We're going longer than my battery wanted to go. Anyhow, so in this particular case and in other cases, the angle was completely destroyed with the exception of the cyclodialysis cleft. And I'm actually old enough to have done cyclodialysis as a glaucoma surgery. I was trained to do that. We used to do that in combination with intracapsular cataract extraction for combined surgery. The problem, cyclodialysis cleft can be either, the problem is it's very difficult to titrate it. It's either too effective and you get hypotenuse maculopathy, or it's effective but can close suddenly. And you'll get a very rapid rise in IOP. So we used to use a meiotic in order to pull on the cyclodialysis circular musculature in an attempt to keep the cleft open. And this particular patient never needed, and I don't know if she ever will, any other glaucoma procedure. But if the cleft closes, her pressure will go, I'm sure, to 60 very, very rapidly. So that's why we use a meiotic. And the cyclodialysis is a useful tool if it exists and it keeps pressure within normal range, but those are unusual cases.
Great. Dr. Tassignon, let's go on to your bag and the lens technique, and you use multiple devices in there. Can you discuss that bean-shaped capsular retention device as compared to the normal capsular retention ring? Relatively speaking, how many clock hours, what kind of tension can it provide? I love that technique that you did to kind of encapsulate and then do the intrascleral flange fixation using the 6.0 proline too.
Yeah, well, I think there is a misconception there. The bean-shaped rings, they are not put within the capsular bag. They are put on top of the anterior capsule so that they can clip the bag in the lens at in the groove. One side is positioned in the sulcus, the other side is inserted within the sulcus of the lens. We have developed that bean-shaped ring in order to center it, loose zonules in elderly patients. We have also devised that in 13 millimeter in different sizes so that it can, based on white, we add white to white plus 1 or white to white plus 2. Everything depends on the sizes of the anterior segment of the eye.
Marie-José, I have a comment for you. Have shown to me for years a marvelous, fantastic surgeon. And my idea is that it's really mandatory to build a huge experience in manage these cases. Because when everybody watch to the video with a tension ring, everything seems easy. Well done, with no complicated situation. But you know that in long-term follow-up in Germany, it was a time that they put a tension ring quite in every single cases of cataract surgery. And after some years, they stopped because the bag started lagging when you perform the surgery, and after years is changed tremendously. And anyway, also surgically, to have the capacity to manage, to make the right choice, to have available the right size, and to have the knowledge to apply properly the perfect solution. In some cases that normally for a surgeon are not so so common, because maybe that you have to manage this very rarely. So my final comment is you are a master and I respect deeply you, but I suggest to my colleagues that when they face something that is unusual for them, to refer to a surgeon with a practical experience and a design and intelligence in working to this surgery.
Rohit,
I agree with
let's
you.
stop.
I
Rohit,
think, yeah,
we should.
I think we
go
should
shortly.
wind it off because we have already overshot by quite a few minutes. So thank you everyone for such an exhilarating session wherein everyone put in inputs which would have been helpful to each one of us. At least I learned a lot from this session. I take this opportunity to thank each one of you in the audience from across the world for making this IIRSI 2020 a success. And I would be falling short of words if I do not thank Dr. Amar, Dr. Ashwin for putting up such a brilliant show. I think we have touched more than 12,000 registrations, which is a record by its sorts. It is registrations, no Facebook, no YouTube, nothing. So cheers to Dr. Amar for putting up such a great show. Thank you very much.
Well done. Thanks a lot. The last session was the best, in my opinion. The last session was the best. The best is always for the
Bias. you. Thank you, guys. You guys have a great one.
Okay. Bye, everybody.
Thank you.
Bye-bye. Thank you.
all.
Good to see you, everyone. Thank you.
Good, sir. Thank you very much.
Cancel si fa.